Hello, everyone. Thank you so much for joining us. We're about to start the meeting. I'm Alice Norton, one of the meeting organisers. I'm just going to mention a few housekeeping points before we start the opening session. Abdel, can I have the next slide, please? That's fantastic. So just to let you know, we have live translation services available for this meeting in French, Portuguese and Spanish. There's been some instructions posted in the chat, and there'll be a slide after this one in the different languages to explain how to do that within the function in Zoom. To the speakers of the meeting, thank you very much for joining us. And please remember, for the benefit of the translations, to take some brief pauses whilst you're speaking. It's a really full agenda, and we want to leave plenty of time for discussion. So we'll be doing some strict timekeeping. If as a presenter you hear a tone, that means that your time has run out, and please do wrap up to leave time for the other speakers. Also, just to note that today's meeting is being recorded, and we'll publish the links to those recordings soon for any of you who miss any sections. We really want to encourage discussion in the meeting. So apart from the opening and closing sessions, for the 4 thematic sessions, please do use the Q&A tool at the bottom of your screen and add in questions. And you can also upvote people's questions to make sure that the panelists answer those questions that you feel as the audience are most relevant. Please make sure if you want to ask a question to one speaker in particular, you include the speaker's name with that. So alongside that, apart from to remind the speakers that if you have any technical problems, to please contact Abdel at the link there. We'll now start the meeting. So thank you for joining us. I'll pass on to Professor Charles Vasongi, the Vice Chair of GloPID-R, to start the opening session.
Hello and welcome to the meeting on COVID-19 research in low and middle income countries. My name is Charles Shea Wisonge, and I work at the South African Medical Research Council, where I am the director of the South African Cochrane Center. I am also a vice chair of GloPID-R, the Global Research Coalition for Infectious Disease Preparedness. I have the honor of chairing the opening session of this meeting. The objectives of this meeting are to discuss emerging research findings and ongoing research activity on COVID-19 across low and middle income countries. 2, identify important obstacles and both unmet and emerging research priorities for COVID-19 in low and middle income countries. And 3, to identify what has worked and how to enable cross-setting learning for ongoing response and future research preparedness for epidemic. This is a 2-day meeting with exciting discussions across both days. Each day, we will explore case studies from different settings across the session themes to enable cross-setting learning. We will focus on how well existing research structures have pivoted and what the remaining barriers to research are. We have 4 thematic sessions with researchers paired with funders as co-chairs and plenty of time built in for panel discussions and questions from the audience. The meeting is jointly hosted by the GloPID-R, the UK Collaborative for Development Research, UKCDR, and the COVID-19 Clinical Research Coalition, who have all come together because of their shared interest in this area. We will hear opening statements from all 3 organizations. And the opening statements will be done by Professor Peter Piot for UKCDR, followed by Professor Charo Kaushik for GloPID-R, and Dr. John Kengasong for the COVID-19 Clinical Research Coalition. Dr. Tedros, the Director General of the World Health Organization, who was planned to give opening remarks in this session, will now provide his remarks tomorrow morning. And I welcome you to come back for those remarks and the rest of the meeting. Following the opening remarks today, we will have presentations on the development of regional research priorities for Africa by Dr. Moses Alobo from the African Academy of Sciences, and COVID cycle mapping and analysis by Dr. Alice Norton and Dr. Emilia Antonio. Each speaker would briefly introduce herself or himself before proceeding with the remarks or the presentation. And I will now call on our first speaker.
It's a pleasure to be here today. So good morning, good afternoon, good evening, wherever you're joining us. My name is Charu Kaushik, and I'm the current GloPID-R chair, and I'm also from Canadian Institutes of Health Research, Canada. So I'd like to start out by thanking the UKCDR and the COVID-19 Clinical Research Collaboration Coalition for their partnership with GloPID-R in helping organizing this meeting. On behalf of GloPID-R, I'm delighted that we were able to organize this meeting and very pleased that we have over 1,000 registrants to this meeting. So I'm going to start out and give you a 5-minute overview of GloPID-R. Many of you may not know this organization or may have some idea, but in next 3 to 5 minutes, I hope to be able to give you a little bit more information about GloPID-R. So GloPID-R is an international network of research funding organizations that are investing in research preparedness and response to infectious disease epidemics. Next slide. In terms of the organization, it was launched in 2013 through the Heads of International Research Organization initiative. And currently it has 29 members and 3 observer organizations, which are really focused on allowing exchange and communication between each other and with WHO and other key stakeholders. The organization is currently funded by the European Commission. And basically the goal is to bring together funding organizations that invest in research related to new or re-emerging infectious diseases in order to increase preparedness and facilitate rapid research response to outbreaks with pandemic potential. So the 3 objectives, which I will get a little bit more detail into and give you some examples, include research preparedness activities during the pandemic or during an outbreak or epidemic, the rapid and aligned funding for research in those emergency situations, and finally, to increase GloPID-R's visibility and capacity for influence. And today's meeting, we are particularly delighted to focus on issues that are close to LMIC issues, and to be able to use that to leverage what focus we can bring to issues that are there in the low and middle income countries. Next slide. So just to give you an overview of some of the activities that GloPID-R has undertaken in the last 6 years. In terms of preparedness, the GloPID-R activities, there are a number of working groups which have focused on peacetime activities in terms of preparedness. So for example, developing of research priorities, there are reports, number of reports that GloPID-R has published. For example, the research scope and outline for chikungunya and some of the other diseases that have the capacity for epidemic proportion outbreaks. Infrastructure readiness that can be pivoted for response. Clinical trials network working group is working very closely on how clinical trials can be coordinated globally during the outbreaks. And this is preparedness activities to get ready for when epidemic outbreaks happen. Similarly, the GloPID-R has put out a roadmap on data sharing, which lays down the principle of how global organizations and researchers can put together a framework for data sharing. In terms of pandemic response or emergency response, GloPID-R has funders have participated in rapid funding research responses for different outbreaks in the past years. Ebola in 2014 and again in 2018, Zika in 2015, Lassa in 2018, and then of course for the last 15 months or so, the focus has been on COVID-19. We worked very hard with our partners like WHO last year to put together the meeting in last February the WHO GloPID-R forum, which led to the research roadmap that has been widely adopted across the world by many funders and researchers. We also worked hard to identify gaps in research and investments in partnership with UKCDR, putting together a funding tracker which indicates align with the WHO priorities, where the areas of funding, strong funding versus needs for increased investments are. And then organizing scientific meetings such as the research synergy meetings in last summer and long COVID meeting in December 2020 to identify and build on the research agendas in these areas. Finally, we are working very hard in strategic partnerships like the one that has led to this meeting today, the COVID-19 Circle Initiative with UKCDR, which is guiding the newly formed GloPID-R LMIC working group that has now put together this meeting. So very appreciative of the work of these groups today. Next slide. I just want to spend 1 minute talking about the LMIC working group from GloPID-R and this COVID Circle partnership that has led to this meeting. The main aim of this COVID Circle partnership between GloPID-R and the UKCDR is to align and strengthen the global efforts on COVID-19 research in resource-limited setting, with the 3 different objectives under it. Coordinating the funders, coordinating the researchers, and then finally facilitating the learning by embedding principles of learning and evaluation. And it's under this area that today's meeting has been organized. Next slide. And then finally, just a word about looking forward for the GloPID-R activities. We are currently working very hard to identify research priorities for the next 1.5 years or so, 12 to 18 months. Clearly, the pandemic is in a different stage now with the coming of the multiple vaccine choices, but also the emergence of the variants. So under a scientific advisory group led by Professor Marian Koopmans, there is work currently undergoing to identify COVID-related research needs and priorities for the next 1.5 years. And the hope is that we can build in resilience in that plan in identifying the priorities to cope with uncertainty. After this 12 to 18 month planning, we will then undertake longer-term pandemic preparedness planning, taking into account the lessons learned from current COVID-19 pandemic. The meeting that is taking place today and tomorrow will really inform and feed into these plans for that longer-term planning, but also identify what is needed in resource-limited setting for next 12 to 18 months. And I just want to end by saying that GloPID-R currently has a very strong priority in understanding the LMIC research needs and gaps. And we are very focused on increasing the membership from the Global South and representation in GloPID-R to really increase the collective impact of the funders and researchers' voice in research funding. So with that, I thank you for giving me the opportunity to tell you about GloPID-R and look forward to hearing what emerges from the next 2 days of discussion. I wish everybody an excellent meeting. Thank you, Charles.
Thank you, Charu, and thank you for the excellent remarks on GloPID-R. It's now my pleasure to introduce Professor Peter Piot, who is the outgoing chair of the UKCDR scoreboard. Over to you, Peter.
Good morning, everybody. Bonjour à tous. Buenos dias. Bom dia. Very happy that there is translation because it's something that we assume too often that the whole world speaks and understands English. Thank you so much, the organizers, and I'm delighted that this is a joint effort between UKCDR, GloPID-R, and the African Union, but Africa CDC, but then the Clinical Research Coalition. Now it's hard to see positives through the tragedy of the COVID pandemic. As we all know, the impact has been catastrophic for many people, societies, just name it. And it's likely that this will go on for quite a while, that this will become more of like an endemic type of situation. However, science has really provided a glimmer of hope. And it's to the credit of, sure, many of the participants that today, roughly a good year after the the start of this pandemic, that we know so much more, but there's so much more that we need to know. And I'm speaking here as the outgoing chair for a few more days of the scoreboard. SCORE stands for the Strategic Coherence of ODA-funded Research Board, which oversees the work of UKCDR. And I'll tell a bit more about UKCDR in a minute. We've been there for quite a while, but the COVID epidemic has really highlighted how important it is to not only organize research in the midst of a crisis, and that has its challenges, but also that if we have a vaccine today, for example, it's thanks to investments of decades of the basic science. And if we have had better understanding of the transmission dynamics, the epidemiology, clinical work, it's because there's an infrastructure, people have been working. These things don't fall out of the sky. And that's why I think this meeting is really creates a rare opportunity to bring research funders and the researchers themselves to have a frank discussion about the challenges and opportunities to undertaking research during a pandemic. Because we're all incredibly busy doing crisis management, basically, but it's always important to take stock and to also take a long-term view, because this won't be the last epidemic or pandemic even, and we need to make sure that not only we're doing a better job in terms of this current pandemic, but also for whatever comes next. And whilst there are many research questions that are globally applicable during a pandemic, context-specific research is also vitally important. And that's even for biological interventions. Look at what happened, the vaccine trials, where it was so important that they're not only happening in Western countries, but also in Brazil, in South Africa, because the results were quite different because of, as we know, variants, but there may be other factors, genomics and so on, genetics. And so too little research has been conducted on COVID-19 for resource-limited environment. And so that's why today and tomorrow, I'm really looking forward to hearing about the challenges, but I always look at the future and the opportunities from research on COVID undertaken in low middle income countries and identifying specific and immediate research priorities. Let me say a few words about UKCDR, one of the three co-organizers. We are a group of government departments in the UK and research funders working in international development. For over a decade, we've brought UK research funders together to discuss priorities and coordinate efforts to garner maximum impact. And the UKCDR is governed, as I mentioned, by this scoreboard, which I have the honor to chair, and it's always chaired by an independent member, and it brings together the chief scientific advisors and directors of our co-members. We've pivoted to strengthen both the UK and global funding response to COVID in low middle income countries through our COVID Circle initiative in close collaboration with GloPID-R, as we just heard from Charo. And this COVID Circle really has aligned funders to a set of 7 joint principles. 7 principles to support high quality research for the most pressing needs in epidemics and pandemics, and building on global best practice, as we heard. I won't go over all of them, but it's really important that when we are doing research under challenging conditions that we are guided by such principles. And that goes from, you know, making sure we also are investing in research capacity for rapid research, but also this equitable partnerships, open science, protection from harm, ethical considerations, and so on, and strong collaboration. Now, the work of this COVID circle over the past year, is only a year by definition, is in existence, has sought to support three principles, including through identify these principles and identify research priorities for COVID-19 and of particular relevance to researchers from low middle income countries, mapping and analyzing the global research funding response through the COVID-19 research project tracker by UKCDR and GloPID-R, and establishing a living mapping review on Wellcome Open to improve the coherence of research response. And for those who don't know it, go online. It's really very useful. I use it, and you know, it's a very precious resource. And then thirdly, to launch the COVID Circle Researcher Coordination website to support collaboration among scientists. We've also produced, as UKCDR, specific guidance on safeguarding for the COVID-19 pandemic, and it just launched a new hub on equitable partnerships, something that's really close to my heart. And I think that every crisis is an opportunity, and this should be another opportunity for promoting equitable partnerships. All this is, of course, not possible without adequate funding, without money. And when you look at the vaccine research, if we have it, it's not only because we have these decades of investments of basic science, but also because of massive, huge funding. That's why, I mean, I cannot not mention the huge blow that COVID and other ODA-related research is being given by the UK government by dramatic cuts up to 70% in the budgets. And you know, this is going to have a long-term impact on such research, not only for UK investigators, but a lot of that money has been going to partners. So it's something that we should make sure that we are mindful of the fact that equitable partnerships are only possible if there is also decent funding. And that is something that is very, very key, and as scientists, we should not be naive about that. So to end, you know, this meeting for us represents an important opportunity to consolidate the first phase of the COVID Circle initiative and to inform the next steps. Co-hosting with GloPID-R and the COVID-19 Clinical Research Coalition is very welcome and necessary. We can't do this on our own, nobody can. And this facilitates strategic activities, all to reach the same goal of urgent global coordination and ensuring equity and access to both research and the products of research, because that's the next step and that's really important. And that's why I'm so pleased also that after me, there will be John Kengasong will speak, because as head of Africa CDC, he's been really instrumental in ensuring many things within Africa, that there is collaboration, that there is much stronger capacity than, for example, 7 years ago during the Ebola West Africa outbreak. And that I'm very pleased to the fantastic announcement of the contract that the African Union, presented by President Cyril Ramaphosa, signed with J&J to deliver 400 doses of the COVID vaccine to the continent, in addition to the 500 million that ODA as COVAX is supposed to give. So that is a major breakthrough on the road to vaccine equity, although we still have a long way to go. So thank you to all the co-organizers, and thank you also to Marta Tuffet and her team to make this meeting a success already. Thank you very much.
Thank you very much, Peter, and thank you for those remarks on behalf of UKCDR. every crisis is an opportunity, and thank you for reminding us about that, and also the importance of funding. Thank you so much. So I will now hand over to Dr. John Nkengasong, who is the director of the Africa Centers for Disease Control and Prevention. Welcome, John. Over to you.
Thank you so much, Charles, for the kind invitation to be part of this very important conversation. And let me also recognize those who have spoken before me, Peter and the first speaker. And they really touch on key issues that I would like to not repeat those, but rather endorse those and then touch on three key areas. First of all is really recognition that the research that we have all as the globe seen happen is remarkable in the area of COVID response. Remarkable progress, but remarkable challenges ahead. And as Peter said, we have to assume that there's a lot we don't know about this virus, and we will be learning going forward. The speed of the research has been remarkable, both in the areas of understanding the sequences of this virus, identifying the diagnostic tests just within, I would say, few months, to developing a vaccine, going through clinical trials, and then using the vaccine already. I think that has been tremendous progress that is unprecedented in the history of infectious diseases. My second remark is that despite all those remarkable progress, we've learned three things from COVID-19: that we are more connected as a humanity than we thought we were, that we are at the same time more vulnerable, regardless of whether you live in the global north or global south, than we thought. And lastly, that the inequities that we knew existed have been really much exposed by this virus. And that includes inequity in research, which is the topic of this conversation. And I think we fought we fought the first wave of this virus or this pandemic with public health measures. But the end game of this pandemic, whether we actually eliminate it or we move into an endemic situation, will be determined by the research that is conducted and the science. So I think it's very appropriate that the developing world or low and middle income countries play a central role in all of this going forward. We cannot be only consumers of research, but we should co-create research that is in the right context. That brings me to my third point, which is that any responsible and relevant research has to happen in a unique ecosystem. And the ecosystem for in developing countries, or what is called low and middle income country, has commonalities with what happens at a global level, but has some unique features that I believe this kind of a forum will seek to address. And there are four things that we must look at. I mean, actually 5 things we must look at if we need to develop appropriate research in low and middle income countries that is responsible and relevant. One is the policy frameworks that will create an enabling environment for such research to take place. The second is the political commitment, not just political will, but political commitment that is extremely necessary to advance research in the low and middle income countries. The population, has to be fully engaged and understand the relevance of research that is conducted, and of course the pathogen that we just now know that this virus is mutating very quickly, and unless we are ahead of it, will continue to be very surprised. So I think from that perspective, I would like to recognize some of the efforts that are going on in Africa, is supported mainly by the network, supported by the European Union Developing Countries Clinical Trials Platform, the EDCTP work, that had been on this topic for many, many years and created so many networks like the Pandora and Alert. And I believe that this was almost the day they were looking for to really apply research to solve contemporary problems. So I really look forward to staying engaged in this conversation. And again, once more, thank you for the opportunity to contribute. Thank you, Charles.
Thank you so much, John, and thank you for your remarks. And as you've indicated to us, COVID-19 has reminded us that we are more connected as humanity than we thought we were. And it has also brought out inequity in many aspects, but also especially in research. And that is very relevant to this meeting on COVID-19 research in low and middle income countries. So after these opening remarks from Charu, Peter, and John, we will go now to two presentations as part of this session. And I will now call on Dr. Moses Alobo from the African Academy of Sciences to give his presentation. Over to you, Moses.
I'd just like to thank the organizers of this particular discussion for inviting us to present our work. Not so much to discuss the lists of priorities that we had, but really to show you the process that we took in getting to the result that we finally got. So just checking. Okay, there we go. Thank you so much. So I represent AISA platform at the African Academy of Sciences, and also represent that particular organization within GloPID-R. And together with my dear friend and colleague, Kevin Marsh, we co-chair the COVID-19 intervention within the African Academy of Sciences. And the work that I'm going to be talking about brought together more than 1,400 scientists within, mostly within the African continent. So next slide. When the pandemic started, there were some contextual issues that we needed to just put into focus for COVID-19. So of course, we all know most of these things, but I'll just say that 20% of the disease burden still is in Africa. 90% of informal food markets would be what are serving the African continent, to the extent that if you were to institute non-pharmacological measures of social distancing, then what does that mean to the population? Of course, there is a quarter of the population living in extreme poverty, some challenges around the health system capabilities and access, but there are also some mitigating factors as regards COVID-19, to the extent that the rural to urban ratio is 3:2. And then there is a high youthful demographic dividend that was recognized and was seen during this particular pandemic. They are very limited to no care homes or elderly settlements. And then, of course, there's been talk about low mobility index on the African continent. Next slide. So the work that we were doing, especially around scientific prioritization for COVID-19 and epidemic preparedness, came at a time when the African Academy of Sciences was also looking at other scientific priorities. And at the moment, whatever you see on this particular slide is what has been done so far. The target is to do 15 of them in various different areas of science. So we were quite happy to integrate epidemic preparedness into the work that was already being done. We encourage you to go to the AIS website and have a look at some of these other priorities if they are areas of interest for you. Next slide. So if you are to assume this to be a timeline, we started off with an all-hands webinar where just about 275 scientists attended. Of course, we picked out and recorded the discussions that were had. And then after that, we integrated those with the work that had been done by WHO and the GloPID-R, really looking at the research roadmap for COVID-19, and then seeing are the 9 areas corresponding to what is of interest to the African continent or not. We converted those particular sentiments into a survey that we sent out to various different groups, eventually getting 844 completed responses in 2 areas, both qualitative and quantitative, and then went ahead to do a repeat survey 6 weeks later, but this time working, that's number 3 there, working with the UKCDR, UKCDR, and also the Global Health Network. And then eventually what came out of that is a list of priorities that we thought were relevant for the African continent. The question that was then asked when we brought this to our other colleagues at the WHO Afro and also Africa CDC is how do we convert this into actionable questions? And I'll be discussing those a little bit later. Next slide. So these, of course, you all know the 9 original buckets, as it were, for the GloPID-R WHO roadmap. There was free text in the work that we were doing. And after the first survey, there were 17 additional potential priorities that came from the consultation process that were added into the list at some point. Next slide. These particular priorities grew up to around 58 different ones that needed to be done, including things like environment, sewage, and other areas, One Health, that had not yet been considered within the WHO roadmap. And then we worked, as I'd said before, with the NEPAD, UKCDR, and the Global Health Network to do our updated research development goals for COVID-19 in Africa. And in this one, the survey respondents, various different actors within the low and middle income countries, with translations having been done in English, Spanish, Portuguese, and French. We were happy to note that 623, just about half of them, actually came from the African continent, therefore allowing us to do a regional assessment. And that is the report that you see there close to number 3. This particular work also encompassed long-term and short-term priorities using, basically it was a mixed study seeking the views of the global research community, trying to understand which are those areas that are most pressing and which ones are those that should be prioritized for the local region. And you can tell from the publication that eventually went into the BMJ Global Health that there was a shift of prioritization from vaccine and drug development to assessing effectiveness, risks, benefits in the public health interventions. And because we were repeating this 6 weeks after the first survey, it was also pretty clear that there was a temporal nature of the research priorities, that they actually changed within those particular 6 weeks. Next slide. So just to give you an example about initial thinking and how things have changed so far from the beginning. There were, some of the areas that were initially of interest was, for example, special focus on potentially at-risk groups, malnourished individuals, HIV, TB, and sickle cell, if you remember. And then if I was to pick another one, I would say protocols for the management of severe disease in the absence of intensive care and facilities. Next slide. And then just to highlight that the additional priorities, which you can see on this particular slide, are starred. There's a red star to them, showing that therefore, eventually, when we put out the priorities for survey by the various different groups during the first survey and also during the second survey, it was clear that some of the priorities that had been inserted were considered to be high priority compared to those ones that were there before. Next slide. And then eventually, last slide, that we ended up with a policy paper through our convener, Akona Shagela, of the Africa CDC, of the Science Standards and Regulations Technical Working Group. And here we worked with the African Union, Africa CDC, WHO, AFRO, and also the African Academy of Sciences, really picking out 6 different areas of interest, and then eventually utilizing 67 experts whom were convened by these different organizations to now convert the development priorities into actionable items. And on the right of this slide is an example of priority areas and their actionable items that we needed to actually have a look at. So at the end of it all, I encourage you to look for this policy paper, send it to the organizers, and if you can have access to it, it will be nice. So we've learned that there's a temporal nature of research priorities. They keep changing. We hope we can be able to repeat this exercise and see where we are at the moment. And then there's definitely a good collaboration going between Pan-African organizations, and we hope this continues post the pandemic. And then, of course, lastly from me, we think that this will be a useless document if it cannot be utilized and converted into action, and we therefore encourage everybody to have a look at it and action it, as it were. So thank you so much, Charles.
Thank you so much, Moses, and thank you for showing us this work about research priorities in Africa, and for reminding us that research priorities change. And that is why when research priorities come up, they need to be acted upon. And this can only be done best if there is a collaboration between the funders and researchers. And I think discussions in this forum, in this meeting, should help us come closer to doing that. And I will now ask on our next speakers are going to be Dr. Alice Norton and Dr. Emilia Antonio to provide us with COVID cycle mapping and analysis. Over to you, Alice and Emilia.
So just to introduce myself, my name is Alice Norton. I lead the COVID Circle initiative across the UK Collaborative for Development Research and GloPID-R, the Global Research Collaboration for Infectious Disease Preparedness. You've heard a little bit about this initiative from the opening speakers. Today, I will be speaking about some mapping and analysis work we've been doing through this initiative, along with my colleague, Dr. Emilia Antonio, who is a clinician from Ghana, who also conducted her MSc thesis alongside this work. Next slide, please, Abdel. So, as some of you may be aware, when the COVID pandemic sort of broke, the WHO and GloPID-R organised this joint meeting to identify research priorities. Moses has alluded to this in the last presentation. UKCDR and GloPID-R then came together to set up a funding tracker. This is a database of funded research projects on COVID-19. And the idea was that through giving visibility to that funded portfolio, it would help both funders and to researchers to align their research response to identify gaps and opportunities to inform research agendas. And certainly at both UKCDR and GloPID-R, we've used this frequently to look at where different funders are funding and try and create a more coherent response. The tracker covers the complete spectrum of research projects across COVID-19, so it isn't clinical specific. And currently, as of last Friday, we've got over 9,000 research projects catalogued within that, which have been funded by over 132 funders, with the projects taking place in over 100 countries and representing an investment of over 4.2 billion US dollars. What's really important is that within that tracker, what we're doing is we are coding those projects as to which of the WHO priorities and sub-priorities those projects address to enable us to track the global research response against that and see if there's any gaps. As Charles has just also mentioned, priorities do change and do evolve. So in addition to those WHO categories, we have been categorizing against emergent themes in the research response, themes such as long COVID, which are research areas which have evolved since that original roadmap was set up. We've also importantly been coding against the location of where the research will occur. And more details on the analyses on this, which we are updating every quarter, are available on Welcome Open Research, and the latest version of this will be published next week. Can I have the next slide, please, Abdel? So that hasn't quite shown up properly on my screen. I don't know if it has on yours. What this slide is meant to show is the distribution of those research projects globally, which we are mapping under this. And what you can see in the graph at the bottom is where those research projects are taking place. And given the stated aims of the COVID Circle Initiative, particularly interested in the apparent gap in terms of context-specific research taking place in low and middle income countries. And as you can see, the vast majority of the research activity during the pandemic that we've managed to capture has been taking place in high-income countries. What we are therefore also doing is looking at how this funded research aligns to the research priorities that Moses has just outlined in his previous presentation. And I'll pass over to my colleague Amelia to update you on the results on that.
Thank you. Next slide, please. Yes, so the COVID cycle played a role in determining what the research priorities that are of particular importance within low and middle income countries. And we undertook a collaborative study with the African Academy of Sciences and the Global Health Network, building on the WHO roadmap and the Research and Development Goals for Africa report, which Moses has just described in the previous presentation. And in this study, we identified some key context-specific priority areas, including those related to improved diagnostics, a focus on co-infections and COVID, health systems research, some indirect health impacts, environmental impacts of COVID, and some cross-cutting themes around the use of technology in various aspects of the COVID response in low and middle income countries, as well as cross-disciplinary research. And the detailed methodology and the list of all the priorities are outlined in a BMJ Global Health publication. Next slide, please. So in our most recent analysis in the Living Mapping Review, we found that the COVID-19 projects in low and middle income countries, when aligned to the WHO priorities, are similar in the in spread to the global picture. But we also had several of the projects that align to the low and middle income country specific research priorities. And as Alice has said, beyond the limited research in low and middle income countries in general, we've identified some important specific gaps around healthcare worker support, effective PPE use, community engagement, and health systems research. And the detailed findings are available in the next iteration of our Living Mapping Review of COVID-19 funded research projects, which will be published later on this week. As has been highlighted in Moses's presentation, we recognize that the research priorities are evolving as the pandemic is, and we hope that this meeting will identify the remaining gaps and priorities in funded research in low and middle income countries. And we are very keen to incorporate the findings that come out of this in our future analysis. Next slide, please. Yes, we'd like to thank our funding partners, and I'll hand over back to the chair. Thank you.
Thank you so much, Alice and Amelia, for giving this wonderful presentation. And it is now my pleasure to thank all the speakers from Peter, Sharu, John, Moses, Amelia, and Alice that have set the tone for what is going to be a very exciting meeting across the next 2 days. Now we move into the first of our 4 thematic sessions, starting with clinical research networks and clinical research. I will now pass you to my colleagues, Mr. Jean-Marie Barugira from EDCTP and Professor Nick White from the Center for Tropical Medicine and Global Health. Thank you to everybody for participating in this session, and I invite you to join the next one.
Thank you very much, Charles. I'm going to kick off. My name is Professor Nick White. I'm a professor of tropical medicine here in Mahidol University in Thailand, and also at Oxford University in the UK. And I chair the COVID-19 Clinical Research Coalition. Our coalition was 1 year ago with the objective of facilitating COVID-19 research in low resource settings. We have 200 institutional members from 60 countries and 155 individual members from 54 countries. All of us want to reduce the suffering and death caused by this virus as soon as possible. And medical research is a critical component of this effort. But this effort is not distributed equitably, as you've just heard from Alice and Amelia. In general, as ever, the poorest come last. So today, in this next session, which is specifically dedicated to clinical research, we have an unusual opportunity to tell the truth, to present to global funders the reality of trying to conduct relevant research on COVID-19 in resource-limited settings. And if we have one message, it is that the voice of active representatives of resource-limited settings should be heard in making the big decisions about research direction and research funding for COVID-19. So now I'd like to hand over to my co-chair, Jean-Marie Barugira, to introduce the rest of the session.
Hello, good morning, everyone, or good afternoon, good evening. I see you are joining from different continents from across the globe. Thank you very much for joining us. I'm Jean-Marie Barugira. I'm based in the Netherlands. I work for EDCTP, which is the European Developing Countries Clinical Trials Partnership. This is, in a few words, a Europe-Africa partnership to carry out clinical research taking place in Sub-Saharan Africa. And I represent EDCTP within GloPID-R, and I've been organizing these meetings with the colleagues who have been talking to you, the why and how we are going to deal with the questions that LMICs are facing. It is very important to have this meeting, as you heard from the previous speakers. We all know how long it took for LMICs to initiate research response for studies to take off there. Now we are seeing the gap between the vaccine entry into countries when we compare LMICs and the rich world. These things are very dear to GloPID-R and the partners, the coalition, the partners in UKCDR, EDCTP, and other like-minded organizations. So I will not take long in introducing what has been said, but just to thank the participants and to remind you that there's a Q&A for you to pose the questions. If a participant notices that a similar question is being repeated, you can upvote that question and we'll take those later on. After the brief presentation, we'll have a panel discussion and we'll do our best to pick most upvoted questions in the panel discussion. Without delaying, I'll just invite my friend and colleague, John Amosi from Ghana. John is based in Ghana in Kumasi at the Kwame Nkrumah University of Science and Technology, and is going to take a few 5 minutes and tell us about what has worked and what could work and how we should deal with the questions challenging the LMIC settings. Thank you.
Well, thank you very much for that introduction, Jean-Marie. I'll just go straight into speaking to clinical research networks and clinical research specifically. I'm really excited about this session. I can see there's many from all over. And I'd like to introduce to you a partnership that has existed pre-COVID, which is the ALERT Consortium. It's the Africa Coalition for Epidemic Research, Response and Training. And this is a multidisciplinary consortium which is focusing on building patient-centered clinical research, to be specific. And the aim is to respond to pandemics. This was motivated in part by the Ebola epidemic and the recognition of the paucity of the research capacity across the sub-region. And it's comprised of 21 partner organizations from Africa and from Europe, as you can see from the map that I'm showing you right now. I just want to give you an example of some of the work that was going on pre-COVID, which is really important and relevant, and actually provides a firm platform to allow for even more important COVID research. And this is the FISA study, which is a prospective observational cohort study of adults and children presenting at the emergency rooms of health facilities, particularly looking at just what the outcomes of fevers are and what the potential causes of these are. And if you look to the right of the slide, you would see what the inclusion for this kind of study is, and hope that we'll have the opportunity to present results of these once we do have them. It is ongoing. But more importantly, specific to COVID, ALERT has been alive by taking the ISARIC clinical characterization protocol and holding wide consultations across clinical researchers in Africa to develop what we call Africa-ready documents, which we can apply towards exploring the clinical characterization of COVID in Africa, which is so critical, given that there's so little known about the disease in Africa. And the world took the lead in trying to describe the clinical features, presentations, outcomes of COVID. And it was really important, given the unique settings in Africa, that we will be able to do the same. Already we see clearly so far the unexplained epidemiology of the disease in Africa, and it should even all the more point to the need for an appreciation of the clinical characterization specific to the region. So we were able to secure some funding through the Welcome to carry out this clinical characterization work across countries in the sub-region, including Ghana, Senegal, Cameroon, Uganda, and Kenya is involved. Malawi is also running the clinical characterization protocol, but this has been outside of the ALERT consortium, although we do connect with them via the ISARIC platform. Now, what is most interesting about this clinical characterization protocol is that it serves as a very important foundation on which you can build all kinds of studies, including co-infection studies, which are critical. What is interaction between COVID and malaria, COVID, HIV/AIDS, COVID TB, COVID NTDs like cysto, and so many others? We do not know how these will pan out. Even for diseases like helminthiasis, it's almost equivocal right now, with some suggesting it is protective and others suggesting it is not. It is only research like this that could perhaps provide some answers to these questions. You can layer studies looking at treatment outcomes for steroid use and other medications. Long COVID is another issue which I want to particularly touch on in the next slide. But I just wanted to point out the schematic which explains how this clinical characterization protocol works, where you can use retrospective data, also go prospectively, where you actually take serial samples, including stool samples, urine samples, and any other samples that you would, and you could explore what interactions, for example, as I mentioned, between other infectious diseases and COVID would be. So really a great platform, which you're hoping would layer several other important studies on. Very important also is the design of long COVID studies, and I'm aware Welcome is looking at this, but so far long COVID studies have been largely absent on the sub-region. Only anecdotal evidence so far of the impact this is wreaking. Would be very important to set up these large, reliable cohorts early enough so we can understand long COVID in Africa and how that is panning out. Studies such as seroprevalence studies are things that have been mentioned extensively. They hold a lot of promise for answering important questions in Africa, including things like the association between endemic infectious diseases and protection from SARS-CoV. For example, malaria-induced genetic polymorphism on the prevalence of SARS-CoV infection. And what is this? Could also inform decisions about upcoming COVID-19 vaccine campaigns. So this is just your simple, straightforward seroprevalence study design, which many of us I know are involved in. But substantially, the research funding issues are many, and I think it's important in a forum like this that we unpack some of these. No need for me to touch on what the research priorities are, because from the documents you can see, which Moses and others have spoken, we have gone through a robust process of generating these. But however, there are some important challenges we need to address. One is the government level cooperation. And particularly helicopter research, and the fact that there's large research institutions in the north or in the west for that matter, which may deal directly with governments and LMICs, sometimes completely excluding the local researchers. And sadly, sometimes they end up having better access to data than local researchers. There's also the question of research in tandem with policy making, and how researchers in LMIC sometimes struggle to make connections with their governments and allow their research to inform policy. The chronic separation of the healthcare system from the clinical research system. Of course, this works very well in the UK, not so well in other parts of the world. And also in Africa, we do have these challenges with the close linkage between the clinical research system and the healthcare system, healthcare delivery system. And then finally, the lack of access to national data, which is so critical to generating various indices for measuring, even as proxy data to use as denominators. Some of these, like immigration data, even the frame, the national census frame, sometimes is shrouded in secrecy. Very difficult to use these to do sampling and sample size calculations and so on. So these are issues which, aside the research funding, cash direct, need to also be addressed. And I'm hoping that through this discourse, research funding and research institutions will be able to speak together with governments to address some of these issues. And with that, I'd like to say thank you and hand over back to the chairs.
Thanks very much, John. A large number of very important points that you've highlighted. Let's move east now to Asia, and I'd like to invite Associate Professor Ernie Nelwan. She's a professor and clinician at the Cipto Mangunkusumo Hospital, which is a referral hospital in Jakarta. And we'd like to hear her reflections. Over to you, Ernie.
Thank you very much, Prof. Nick White, for introducing me. First of all, I would like also to thank the organizing committee for inviting me for share my experience in this session. My name is Ernie Nelwan. I came from Indonesia. Should I move my slides or someone helping me? Yes. So I'm using a video to help visualize things. So I come from Indonesia, which is a country with over 16,000 islands. And I work in its capital city, right in Java Island, Jakarta. It is located just next to Bali. I believe many of you know Bali. I work in the Faculty of Medicine, Universitas Indonesia. Working in the healthcare and research in Indonesia and Jakarta specifically can be challenging. Yes, because this is the real situation. We have a poor sanitation, overcrowding, with city that are densely populated, like India, China, and many other populated city. Environmental and climate change challenge, such as natural disaster and flooding, and high prevalence of tropical infectious diseases, also not to mention the non-communicable disease now. So actually different stakeholders already take part in solving these various medical and healthcare problems. And fortunately, I work in IMERI, the Indonesian Medical Education and Research Institute, Faculty of Medicine, Universitas Indonesia, where both education and research is located in one facility in close proximity with the Cipto Mangunkusumo National Referral Hospital and other hospitals that are open to and able to facilitate research to improve patient care and public health. So that sounds good, but then with the support of national and international funding agency have shown their trust in local research capacity and also resulted in many studies and publications on health problems relevant for Indonesia, such as dengue, malaria, typhoid, and so forth, as you can see in terms of diagnostic, clinical trial, and basic science. But then those results are not easily being used to make a policy for the people. The government has these guidelines on different infectious diseases. However, there's still a gap between that and the result of the study. Our president actually already pointed out about the irony of doing research in Indonesia. 3 years ago, there's also a study showing that we actually want to do research, but then the bureaucracy, regulation, intention, politics, arrogancy, litigation is words that we use for the nature of being suspicious towards things. So still there. So even if you have the money, it's not always that easy to do research and put the results on board for services. So the solution is just keep trying and then don't give up. Finish your day with smile. And I would also like to acknowledge here Dr. Sasha and Dr. Ajeng that helped me to providing these slides. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Thank you. We'll now hear from Dr. Cynthia Cruzwood with the MIDOL Oxford Tropical Research Unit Argentina. And that will be a few minutes to hear about the reflections from South America. Thank you.
So thanks for the introduction. My name is Cynthia Cruz. I work in the COP trial as the Africa and Latin America coordinator. I'm going to share with you our experience trying to conduct this trial in low and middle income countries with a perspective from Latin America. I selected this image to start with the presentation because I think it looks like any other image of clinical research and treatments as it has ever been. So high income countries are conducting most of the clinical trials and also are going to be the first one in getting treatments and vaccines. So it doesn't look like we're facing a pandemic that is affecting all of the world. Next slide, please. Mainly when we are seeing currently that most cases of COVID-19 are coming from Latin America. So COP is a multicentric randomized placebo-controlled trial that is looking to evaluate if chloroquine and hydroxychloroquine are useful in the pre-exposure prophylaxis. And as you can see from the map, from March 2019, we have evaluated up to 40 countries, which are all the dots, and in green are the dots for those countries that have been activated and are conducting the trial. It's only 7, so something happened in the middle. You can see also the image of a retracted paper that was published in May last year, and that said that chloroquine was toxic for the heart. Also, this intervention had a mass media coverage and an intense politicization, and this led to a situation in America mainly, and particularly in Latin America, where many researchers just replied that they could not conduct this trial in such political setting. So not at all conducted by science. What else happened? You will see also in orange dots for centers that failed. Those were sites where, for instance, we learned that the virus spread much faster than bureaucracy was moving. So in some countries, we actually got the approval to run the trial where there was no more local transmission. Or we just didn't get approval because of the concerns about hydroxychloroquine with a paper that had already been retracted and with no other information. So we are in the situation where we already know that these drugs do not work for treatment thanks to recovery and solidarity, but we still haven't been able to reply or answer. And as you can see, there's still some violet dots from centers that we cannot activate because we are still either waiting for RA or ethics approval. And to give you an example, the National Ethics Committee of Guatemala can take up to 4 months to evaluate a trial. And thank you. And in Nigeria, that is, you still don't know. You don't know how long can it take. So finally, what has worked? Science has worked. So the answers we have come from solidarity and recovery, and we are science passionate, and we will keep trying to answer this question and to give solutions for this problem. The Avaref initiative has tried to collect replies from several countries, from RAs and Ethics Committee in a short period of time. This has been organized by the WHO African Region Organization. And then I would say, to finalize, thank you, what do we need? Intersectional coordination is a must. We need the governments to understand that an emergency requires emergency timelines. As a scientific community, we need better governance. But my message to funders is, so what are the projects that are going to be funded from now on? How is it possible that we have currently 248 small trials for hydroxychloroquine in pre-exposure prophylaxis, and we still are not able to realize if it works or not? And then science quality must prevail in all the projects. That is my last message. Thank you all very much for your time.
Thanks very much, Cynthia. Thank you for that presentation. Our next speaker is unable to join us, unfortunately, but he has kindly left a recording, and it's Professor Philippe Guérin. He is the director of the Infectious Diseases Data Observatory, and he's also a founding member of our COVID-19 Clinical Research Coalition. So hopefully we will now be able to play his recorded message to us.
Good morning, good afternoon, good evening. My name is Philippe Guérin. I'm unable to join you live for this seminar, being in rural India, but I have recorded this presentation talking about the data landscape in the context of COVID-19 crisis. As part of the landscape analysis, we have been monitoring through the WHO ICTRP database the volume of studies which are registered around the world. And clearly there is a predominance of studies happening in high-income and upper-middle-income countries. This is true as well for therapeutic intervention which are focusing on repurposed drug. And clearly this message is correlated with the fact that the majority of the funding monitored by the COVID Circle is also very much in high-income countries. First, a positive message. There has been a huge mobilization of the research community to conduct studies in the context of COVID-19, with more than 8,500 studies registered to date in a bit more than a year. Having said that, when we focus on therapeutics and in particular repurposed drugs or intervention which will be potentially simpler to implement in LMIC, we see that the majority of the randomized controlled trials which have been conducted so far are of a relatively small sample size, meaning that actually there are very few studies that will give a definite answer. And we have seen that to date with actually very few recommendations being very clear on intervention that would have an impact on COVID-19. There is clearly a problem of duplication of effort and a problem of lack of coordination that I think the community is acknowledging. In the review of data, we found another issue regarding the definition of mild, moderate, severe, and critical patients. So, unfortunately, there have been, as the disease was developing, several definitions developed, and each investigator were also doing their own definition. And this is possibly a major problem, especially in classical aggregated meta-analysis, where you would like to compare population one to each other. And that's clearly very difficult with these various definitions. It's particularly striking with mild patients because the definition seems to be varying quite a lot, not only in the examples that are on this graph, but also in the explanation given by the different investigators in clinical trials. We have seen also different study population and different endpoints. So that is making the whole evidence gathering fairly confusing. To give you an example of the problem, in the majority of the RCTs which are looking at therapeutics intervention for COVID-19, they include a broad spectrum of patients with respect to severity. And so in these two examples, you can see that essentially They are mild patient and moderate patient pulled together in the same RCT. Now, when you put this information, it's very difficult from a publication to dissect who is what and how the intervention is impacting early patient versus a patient with more severe disease. And we know that this is critically important in the context of COVID-19, where the therapeutics will be different, much more focused on antiviral therapy at the early stage and on immune suppression at a later stage. Finally, when reviewing the evidence on therapeutics, it's very clear that the recommendation coming from studies focusing on hospitalized patients has been pretty good and very much driven by high-income country, but giving very clear guidelines on the use of a corticosteroid, for instance, across all countries. However, the assessment of the information that I just presented highlight that for early treatment and prevention of hospitalization, which is very much the focus on the LMIC, the evidence gathered to date are fairly limited and have not been the focus of the intervention. And even when they have been part of the focus, it is very difficult, for the reason I stressed, to dissect this information. And we strongly believe, and this has been a work done as part of the coalition, that the therapeutics review and guidelines should not pull evidence from the whole spectrum of a patient, but should really separate outpatient versus patients who are hospitalized. Thank you very much.
Now we'll pass to Dr. Faik Yong Che to talk about social science. Dr. Faik is affiliated with MAHIDOL Oxford Tropical Research Unit in Thailand, but is also chairing the data sharing working group with the coalition. Over to you, Dr. Faik. Thank you.
So my name is Faik Yong Che. I'm a bioethicist at the MAHIDOL Oxford Tropical Medicine Research Unit. So I'd just like to make 2 points in my talk today. I agree with previous speakers that investment in research infrastructure is necessary. I'll just talk about one aspect of it, which is data management and sharing, which Philippe set the scene very nicely in his talk just now. In this pandemic, there are expectations by research funders that researchers should share interim and final research data as rapidly and as widely as possible. So we are talking about individual level patient data. Our experience working with LMIC researchers and conducting workshops on data sharing tells us that there is a lack of data management and sharing capacity, expertise, and experience. Also, the cost of data sharing. We know it's not free. The question is whether to cost it within the primary study or the secondary study, which means secondary users, rather their funders, have to contribute. Here, I'd like to bring your attention to the data sharing group, which I chair, which helps to share with researchers with data sharing. Second slide, please. So we know that data sharing is difficult and the guidelines are not always clear. And then there's the GDPR, which has very strict data protection or data privacy guidelines. There is a tension between the GDPR and having data as openly as possible. Let me share my specific, very painful experience related to a study of which I'm the PI, which is a SEPCOV study. The objective of the SEPCOV study is to understand the social, ethical, and economic impacts of COVID-19. Because of COVID restrictions, all data collection had to be online. And because it was multi-country involving the UK and Europe, all sites had to adhere with GDPR. In this study, we were interested in those who had worse economic impacts or social impacts, which means we were interested in participants that were by default difficult to reach, mostly not tech savvy, did not have good Wi-Fi at home. We wanted to get a good range of people. For instance, in Thailand, we wanted to interview a monk, street vendors, a masseuse, a boxer, a Muay Thai boxer, hairdressers, because they were working closely with people. Besides using the conventional phone, according to GDPR, Microsoft Teams is the only approved online platform. In Thailand, most people communicate by WhatsApp or Line, not Teams. Microsoft Teams requires the participants to have an email address to set up the online interview. And not everyone has email address, especially in rural settings. Okay, so there were some challenges then. For example, our street vendors were not tech savvy. Our monk did not have an email account. And we were told having the camera turned on was considered high risk of breach of confidentiality. So we had to turn it off. This is not good for qualitative research, which you can't when you can't see faces. In qualitative study, also when you're taking people's time for interviews, it is also good practice to compensate people for their time, even more so during COVID when people have lost their jobs. That means we either had to collect bank account details to bank in their money directly or buy vouchers to post to them, which means collecting their addresses, all of which seem really high risk. So our study took a long time to get off the ground. And there was a lot of data protection wording, as well as data sharing wording in the information sheet. And next slide, please. So what worked for us? We had some existing funding from Wellcome and managed to get some additional funding from WHO to develop an electronic course that's free, that's hosted on the Global Health Network website. We've completed phase 1, and you can see from the numbers on the slide, there is a real appetite for data management training. So in conclusion, I just want to reiterate again, data sharing is difficult. There are many challenges, and data collected are often not of good quality. Investments on data management is really important to enable collection of good quality data, both for use in the primary analysis as well as secondary analysis downstream. At the moment, guidelines on data sharing and data protection are not very clear, or not 100% clear. There's a tension between data sharing and data protection or privacy. That's all from me. Thank you.
Thanks very much, Baek Yong. So the next speaker is Dr. Estevao Núñez. He's the Vice Director of Clinical Services at the Evandro Chagas National Institute of Infectious Diseases of the Fiocruz in Brazil. Estevao, the floor is yours.
Hi, everybody. Thank you very much. I'd like to thank the organizer of this conference for the opportunity to make this presentation. The first slide, please. Next. Okay. So, right now, Brazil ranks second in number of COVID cases and COVID-related deaths. Although test rates are far below world's average in our country, so we can only estimate that this number are underestimated. We're now facing the threat of a new variant that is likely associated with increasing rates of transmission, even in areas where previous herd immunity was supposed to be achieved right now, like Manaus on the north of the country. So concerning demographic, epidemiologic, and virologic aspects, we are in a very particular position at this point, not only in terms of health politics, but of research issues as well. On the other hand, although our medical infrastructure is relatively strong, our most important tool, the Health United System created to deliver healthcare to the Brazilian population and to help inequalities in health access, has been underfunded since its creation, which was exacerbated by recent austerity measures. So now we are facing the lack of ICU beds and even oxygen in some areas. So we have to address this issue in our research perspective. Next, please. Okay. Investigator and clinical research sites of excellence are available in the country. In fact, because of the huge number of cases, it was possible to initiate a lot of national multicenter clinical trials, and doing so significantly contributing to the large accumulated data regarding treatment as well as vaccines for COVID-19, including the role of repurposed drugs like chloroquine, azithromycin, nitazoxanide, and phase 3 studies of vaccine candidates like the CoronaVac already available in the country. Research sites in Brazil has also participated in many international clinical trials. Our country participated, for example, in Solidarity clinical trial launched by WHO as part of the global efforts to investigate promising coronavirus treatment. and it was coordinated by our sites on Fiocruz in Brazil and included 11 research sites all over the country. In fact, this mega trial is a proof of concept, international clinical trial, including sites with different levels of resources working together using a simplified data collection procedure. Next, please. And it also used an adaptive platform design. Because of the rapid geographic rotation on global scale, international clinical trials on an adaptive platform framework are deemed to be the most suitable design. Since major impact is rarely seen in any treatment strategy for COVID-19, we need multi-center trials that include a huge number of patients as quickly as possible, recruiting internationally or from different countries at different times as the pandemic progresses. And because of that, we have to establish a global network of research sites with satisfactory building capacities. Next, please. Expertise on complex clinical trial designs and data analysis, as required, for example, by COVID therapeutic clinical trials, is limited to a few groups in low and middle income countries. So the availability of a centralized technical support on trial design and data analysis would be instrumental to investigators in developing countries. It's important to foster the participation of investigators for low and middle income countries on protocol teams since the conception and design of the protocols. Early participation of investigators and community members in these countries would allow for incorporation of low and middle income countries' priorities regarding COVID therapeutics like test coverage for infected TB or HIV patients, and also to manage severe COVID cases with limited resources. Thank you very much for your attention.
Thank you, Dr. Luis. Now, as you have noticed on the agenda, we are closing the part where we follow specific presentations from countries or representing regions or specific themes. And now I'd like to invite all the 5 presenters to put on the cameras, microphones not yet, and I'd like to invite then another set of panelists who are joining us. First, I'd like to invite Dr. Natalie Strub-Wolfkraft from DNDi. Natalie is with DNDi, but also a member of the steering committee of the coalition. And I'd like to invite Professor Madia Hashmi from Ziauddin University, Pakistan. Everyone is here. Now, we have a lot of questions in the Q&A. Since those were specifically addressed to those presenters who we just listened to, first I'd like to give word to Natalie, talk a bit about the work she's doing with the anti-COVID DNDi, but also address these questions that were put forward to the presenters. What are the barriers, how anti-COVID has been dealing with these barriers, and how anti-COVID can provide a few insights into the solutions. Specifically, what is happening in the LMICs if anti-COVID can inform with the funders and researchers on the way forward based on the experience that has been observed in the last year. Thank you. Go ahead, Natalie.
Thank you, Jean-Marie. Bonjour, good afternoon, good morning, everyone. Thank you for the invitation. So maybe I should say what anti-COVID is. So anti-COVID is a platform trial, exactly as the presenter was saying just before. So it's a large adaptive platform trial looking at treatment options for outpatients conducted in Africa. And I think that's one of the very few large studies that's been conducted in LMICs, which is good for anti-COVID, but maybe we should have more of these anti-COVs. And maybe I would say, so it's conducted with many partners, and I'm sure there are a few on the call today. It is sponsored by different sponsors in the North and the South. It's been co-developed by the leaders and the researchers that are conducting the study. So it's not something that we've just plugged there. It's been the way it's been designed is really to find a solution for outpatients, considering the setting of patients in Africa in that context, in fact, with the objective of limiting patients progressing to severe disease, because we were thinking very early on that it's possible that there wouldn't be enough beds, enough oxygen, enough staff, in fact, to care for those patients. So that was also considering, the setting, which we've not seen so much in, maybe for, in the definition of priorities. So that's what it's supposed to do. And I think it's ticking a little bit the boxes of what we're trying to achieve with this meeting, is really answering and finding research projects that are tailored to LMIC conditions. Also the fact that we were thinking that maybe we should have a study that is not too demanding and that focuses on exactly what's needed. And the nice to have, well, it's optional in this study, but it's not mandatory. So you don't lose time in satisfying, nice things, but not necessarily those things which will respond to the priority question, which is how can you save patients from getting severe COVID? That's the way it's done. Many of the barriers that were presented by the colleagues before we have experienced, but we've also seen good things. First, this study has been funded, so I'd like to insist on that because we are grateful for getting funding for this. Now, in terms of the bottlenecks, and I'll move back maybe and switch to the coalition now, because when we developed this coalition with many, the idea was to focus on what could be identified bottlenecks and try to overcome those bottlenecks and learn from that and improve the community. And some of the bottlenecks were around regulatory approvals, ethics approval, import license. And those, although we've had a lot of chance for this study through the AVAREF mechanism, which even AVAREF itself developed an accelerated process to review COVID-19 related projects. That's fantastic. But I'm not sure it's the case across the world. So I think we should learn from this and maybe also improve a little bit more the AVAREF process by tweaking the import license things. I'm going in details, but at the end of the day, we should go, I think, also in details and not stay too high level. So those are things that worked. In terms of the coalition priorities, I think we need to understand that working groups that have been set up by the coalition had some time to think about what is needed for them. And I'm thinking here what is needed for LMICs in terms of research. And many things came up. Some were discussed there, but I think we can simplify and aggregate these in a few categories. One is we need to better understand the epidemiology here, and we need to understand we need to have a project to biobank. In fact, to be very simple, we need biobanking, a project that allows to collect samples and also to sequence samples. So we need capacity building for this. And we need to make this as one simple global project that is funded and that is coordinated. And all the words that were said by the very prestigious predecessors about the coordination of funders are very key here. And why we need this is to do it now is, of course, we need to understand where the cases are, that's clear, but we also need to understand if the variants affect the response of treatments, or if the treatments are dependent on the variants, or if patients are going to have a new infection in few months after the first one. Is it a reinfection? Is it something else? We need to understand this, and we don't know yet. The other, and sequencing capacity is very important. So all the things that were mentioned by Pei Yong across data sharing and all that need, to be addressed there. The big second project that we need is around excess mortality. I think that was mentioned, maybe hasn't been mentioned, but will be mentioned. That I think yesterday there was some information from Mexico. We don't yet know, but we know we don't know, and we know we should know, because how are we going? This is for now, but it's also for the future, and I'm sure there will be other speakers who will talk about this. And the other projects that we need is to coordinate, of course, all the studies around outpatients, and make sure that what is happening and what was mentioned in Latin America for now, we can learn from there and coordinate all these projects together. And finally, one of the big unknown not well described feature is what is post-COVID condition in different settings. What are the symptoms? What are the risk factors? And can you prevent it? Maybe can early treatment prevent this? We need a coordinated way of looking at this, because if all of us, we continue to have simple, small studies looking at criteria in a slightly different way, that at the end of the day, you can't pool, as Philippe said, that is not going to help the community. So we really need to do that. What I haven't mentioned because of lack of time is all the other questions raised by our working groups, which were on maternal health, which were on social sciences, a lot there, but I'm sure there'll be more speakers to speak about this. So I'll stop here. Thank you.
Thank you, Natalie. Now I'll move to Professor Madia Hashmi. I know you are in critical care medicine and you are based in Pakistan, but also covering a lot of areas in Asia. Also international collaborations, such as ISARIC, you work with them. Something specific you'd like to add to the words of Natalie and other speakers in terms of lessons learned in last year, the barriers, but also some of the solutions you'd like to be proposing, and maybe a word to the funders and to the colleagues research community. Thank you. Go ahead.
Thank you very much, Jean-Marie, for the kind introduction, and I'm very grateful for this opportunity. I'm an intensivist and a very novice researcher working in Pakistan, which is again a huge country of 200 million in South Asia, just like Indonesia there. So what worked during COVID was our existing partnerships. So just since towards the end of 2017, with the help of Mahidol Oxford Research Unit and then later Wellcome Trust, we had established a platform to collect routine data in the intensive care units. So in Pakistan, across the provinces, it's a huge country, but I had about 69 intensive care units on this registry platform, and we were already collecting the data. And then later on, with the help of Wellcome Trust, a Critical Care Asia network was formed, and they have about 230 intensive care units. So this work was already going on. Then when the pandemic started in February and March, ISARIC, which is International Severe Acute Respiratory Infections and Emerging Infections Consortium, they wanted to collect data, roll out a clinical characterization protocol, as John Emesu from Africa has already told. So it was very easy for us because the registry platform was available, data collectors were already trained, there was no burden on the clinicians. So we were quickly able to embed the WHO and ISARIC recommended CCP forms within our registries. And in the last year, the Critical Care Asia network has contributed more than 9,000 COVID suspected and proven patients to ISARIC network. So this worked for us and we are very happy. It would never have worked if the registry platforms were not already in place. So the message to funders is that you don't wait for the pandemics or things. You have to start working ahead of time and establish these networks, establish the bare minimum research infrastructure, enable the clinicians, because clinicians in LMICs are not privileged to have special research time or research tracks. So they are literally earning their livings to their clinical work. So to expect these clinicians to, in a pandemic where there is already shortage of clinicians, to start doing research is not going to happen. But if you have already established such platforms, they can quickly up their work. So we were also able to run an adaptive platform clinical trial, and this trial was not meant for low middle income countries. REMAP-CAP trial is a randomized embedded multifactorial adaptive platform trial which was run in developed countries. But because with the help of these networks, we were able to run REMAP-CAP in 3 South Asian countries, Pakistan, India, and Nepal, and we have about 14 sites, and we are running 4 to 5 domains, vitamin C, antiplatelets, anticoagulation, those. So we were able to do that only because the platform already existed. Obviously, there are barriers. The barriers that what I felt, I can speak for myself in Pakistan, is reluctance to data share. And it's not the technical aspects as Faik has initially alluded, it's just the hesitancy to share data because everybody became very possessive because this was an opportunity to collect data, publish. So I have 69 intensive care units on the platform, but only 21 consented to contribute data because rest of them got possessive and they didn't want to share COVID data. The intensive care units routinely they would share data, but in the COVID ICUs they were reluctant to share data. There were other reasons as well not to share data. One is obviously the fear that maybe you are not doing so well, so you don't want to tell what you are doing. And then there is also a little element of trying to exaggerate your numbers, especially in public sector and philanthropic institutions. So they also don't want to show the real number. So these are the ground realities. It's not these are like not very scientific reasons, but these are the reasons where people are reluctant in LMICs to share their data. And the other thing that I faced was a lack of will from the government. Like this initiative is mostly from private hospitals, from clinicians, their own effort. So the government advocacy is needed. If I tried very hard for the government to take up this registry so that we have standardized data from all the intensive care units, especially from big designated COVID units, which unfortunately are not part. We have contributed 3,000 patients from Pakistan, but most of the patients obviously are not contributed. So I think that's what didn't work for us, but we were lucky to get ethical approvals in time as well. So I think the funders, they have to work ahead of time, build capacity in LMICs, just as a baseline, because the burden of disease, it's not only pandemics, it's all the disease, injuries, burns, all kinds of disease. The burden and the mortality is higher in LMICs. So research doesn't happen overnight. It's a process, and that process should be started earlier on when there is no panic. Build capacity of clinicians, because basic scientists and clinicians, there is a disparity. So clinicians obviously give priority to their clinical work unless they're incentivized, given time, funded to work on projects. And if projects like remap cap, we in low middle income countries did not waste time to invent a clinical trial, but we implemented that trial. So, but in the process we learned so much. All the countries taking part in remap cap are learning. So this kind of learning works better than official training. So I think that's all from my side. So we had good things and we had barriers, but we look forward that these barriers will be gradually overcome and there'll be more research from LMICs. Thank you.
Thank you, Professor Hashmi. Before I hand over to Nick to go through a few questions from the Q&A series, I'd love to hear from John Amwasi, because ISRIC was mentioned and Alert works a lot with ISRIC. Maybe something, because you are talking about a lot of countries in Africa and a lot of countries in South America and Asia, is the model of ISRIC, did it help for you to get quickly information from those countries in the north that were quickly in starting research? How can we learn from ISRIC and similar initiatives in the context of Africa when it comes to time taken to initiate research?
Well, thanks for the question, Jean-Marie. And I think that the role that ISRIC has played in facilitating the flow of information, data, and knowledge across the various networks has been critical. As I mentioned earlier, Alert was able to take the protocol which we had contributed to. This was a protocol that had been developed pre-COVID in anticipation of a possible epidemic or pandemic involving a respiratory illness, or SARI for that matter. So when COVID came around, it was just repurposed and set up. And Alert had already contributed to this. We were able to take this, discuss with colleagues in Africa, and really purpose it to suit what we wanted to do. We connected also with the Africa CDC, connected also with WHO Afro, who were all very supportive in our bid in approach and welcome for funding, which we were successful in doing. Beyond that also, the historic level, we actually worked on some other proposal that was not successful. But the interesting thing is that another historic partner was successful, and they actually brought us on board within this ICU project, which Mariha knows about, and we are contributing in that aspect as well. So it's interesting to see how being part of this federation is providing both the network as well as the critical tools, the knowledge, and we are now also providing very soon the critical data from Africa, which will contribute to the swath of data that already is being produced from the clinical characterizations of COVID globally. So I think it's a really excellent model that can be replicated and actually should be strengthened.
Thank you, John. Now I'll hand over to my coach, Professor Nick White, to take us through the questions that have been posed by the audience. Thank you.
Thanks very much, Jean-Marie. Just a warning to all of the panelists. At the end of this, we need to come up with some concrete recommendations. So before we go, I'm going to ask each one of you, if you only had one wish, what would it be? And that's going to help us in our recommendations for the final session tomorrow. But now I'm going to try and decipher the questions. And the first question is, what are the causes of the failure of clinical trials in several African countries? Anybody want to take that one on? I fear that one's for you, John, as well.
Yes, Nick, I've humbly raised my hand in acceptance. That being said, well, I wouldn't be too sure that clinical trials have failed in many African countries. Maybe what the one asking the question meant was the challenges in getting the research off the ground. I can tell about Handicov, which I lead in Ghana, and Natalie with DNDi really doing a splendid job of coordinating this across 13 African countries. That has worked excellently via the WHO Afro-AVRF process in really providing what is needed to allow the ethics committees across the various countries to have the fuel to get going and provide the ethics, ask the very critical questions that are needed to do good research across the continent. So I wouldn't say that the trials have failed, but there are regulatory challenges, and then the time frames sometimes are longer than would be desired. In a number of African countries, I know that applications have been put in. Sometimes you need to wait for months for meetings to take place, and sometimes there's uncertainty. There is some kind of political interference in some countries for various reasons. These are what are called challenges, which are not limited only to Africa, but I think that the use of the AVRF process, which Antikov did, is one of the ways by which some of these can be circumvented. Also, going to the WHO Ethics Review Committee was one critical step, which made things a lot easier, because a lot of countries will ask, is the WHO aware of this? What have been their comments on this? So of course, if you can demonstrate that you went through the WHO ERC process, it adds another layer of comfort to the countries who want to be sure that they have plugged all the holes and won't be held responsible, or won't be called out for seemingly not having done a thorough enough job. So that's how I would address this issue.
Thanks. Quite a few of these questions are focused on Africa, but I think we can generalize. So the next one is, cross LMIC partnerships have played a key role in advocacy, policy making, and research. Estevao, would you comment on that? Is it any use to you to have partnerships with other LMICs? Do you see that as furthering research and policy making? You're muted at the moment.
Thank you. Yes, thank you for the question. Actually, I think it's very important to combine efforts from many different LMIC, because we have to be aware that when we talk about LMIC, we're talking about very different areas and with particular situations at a different point of times. But there is some issues that we should face together, as like some co-infections with TB, some the lack of resources, the lack of ICU beds, the lack of oxygen. So how do we face those things? I think combining efforts, we could have some more robust data to focus on our special situation. So there's many issues regarding TB co-infection and even immunomodulatory treatment strategies affecting TB co-infection. And we know right now that there will be no treatment strategy will be hugely affect the COVID-19. So it will be important only with a lot of data, only combining data from different areas, from many areas, we should have response to some questions that are familiar to every one of us that are working. As it was said before, we are working with them. We are working as clinicians, so it's difficult for us to work only as researchers, and we have to combine efforts to do that, I think.
Thank you. Actually, could I ask Natalie to comment also on the importance of across LMIC partnerships?
Thank you, Nick. What we haven't seen, in fact, is collaboration across continents on things like treatment for outpatients. And I think it's a problem because it's where probably the problem is of the highest importance. And so favoring this via what we have tried to do with the coalition is one way of doing it. It seems now there will be another initiative here, which is great. We need to come to something very concrete. I totally concur with what you said. But we can't ignore the fact that you know, the variants travel, right? So you can't be isolated in trying to find a response. We need to have the same methodology to understand and respond to the same questions. So without communicating all of us together, I don't see how we'll make this happen. Plus, the way to do this is probably technically, we have these platform trials, which are very adapted to this. They are totally adapted to the way of integrating different aspects and then allowing to have a global way of, in fact, sharing data. It's about sharing data. It's sharing data across different treatments, but it's also sharing data across different continents or different variants, if you wish, but using the same methodology. So you don't have to worry about the fact what Philippe presented before, which is such a heterogeneity of ways of, and describing your patients in and your patients' outcomes. So all of this is how you can do it. So we have the tools. It's just a matter of us being able to communicate better amongst each other so that we integrate and we stop having the fragmented research that hasn't helped the community. I would like to say that, last week, EMA released this feedback on ivermectin after having looked at, there were about 60 trials, I think, looking at ivermectin. I think they considered about 18. And the conclusion was we cannot conclude. So this is exactly why we could, with solid trials, amongst colleagues from LMICs, just work on these solid, as a colleague from Pakistan just said, we have the tools. Let's use them together.
Thanks, Natalie. I have a question on research silos, publication restrictions, and language barriers are still huge detriments to enable clinical research and networks to effectively impact practice. Why is this not addressed? How can we overcome these barriers? Madia, do you want to comment on that? I mean, it's an extension of what Natalie was just saying about fragmented research.
Yes, from LMICs getting published in reputable journals, it's very difficult. The cost aspect is at one hand, but it's also maybe the quality of analysis, because not all researchers have access to statisticians or the complex analysis. So obviously the research, if it is not of a certain quality, does not get prioritized publishing in good journals. And even observational studies that sometimes do tell you a lot, but obviously it's the randomized RCTs that get the priority. So all these things make it difficult for researchers to get their research published in reputable journals. Language barrier, I am not sure how that is addressed, because even if it is published in some other language, the translations are always available. So I really don't know how that would affect the publication.
Perhaps I could also ask Ernie Nelwan. This is about fragmented or broken up research and people not being able to exchange information and so on and so forth. Is language a problem, do you think? Is it an obstacle? How difficult is it to get research going in Indonesia?
I will not say that language will be like the problem actually at this point. Maybe when we are going to write it down to submit it to the journal, yes, probably. But yeah, we did also now English as our secondary language. But as you know, that Indonesia is not only Jakarta and it's not only Bali. So there's also an area that people not really exposed to English, but they do have problem. Like for example, in Lombok. In Lombok, there's an area with high maternal mortality. We have this collaboration with Professor Anuraj Khan from Harvard, but I think now he's in Oxford. But then what I'm trying to say is the people there might not really know English as their second language. So we have to see language barrier as not as one thing. We have a barrier when we are going to do the study, because we have to involve people on the field. We have to have this paper prepare for CRF and so forth, protocols and everything. They have to understand what you are going to do with this study. But then later on, maybe you mentioned or focusing on publication. Yeah, for publication, it's true that writing is not easy. Writing is it's specific words itself. But then at this moment, we have also PhD doing study abroad. We have this agency that can help us to improve the writing. And then if this is a shared paper, I mean, the mentor will taking a huge part, like in Indonesia now, especially in UI, we have this strong collaboration with Oxford, Aikman Institute also. So also in another universities, I believe. So I don't really going to say, or I'm not going to say that the language barrier is like that much important at this point.
Thanks, Ernie. I've got one on data sharing here for Peik Yong. It says the questioner says, I appreciate the need for data sharing, especially in the context of a pandemic. We already have the challenge of scientists based in the global north conducting secondary and other data analysis on data from the global south for publication without inclusion of those responsible for generating the data. So, pre, intra, and post-pandemic, how do we continue to address the current imbalance in the benefits accruing from access to shared data? Peik Yong.
Thank you. Well, this is a very, very, very good question. And the question, you bring a very good point. So data sharing has been, well, there is a potential for exacerbating existing inequalities between high income setting researchers and low income setting researchers. It's been recognized because, you know, data is a currency, and there's a danger that LMIC researchers are reduced to data collectors, and then, you know, the high income setting researchers analyze the data and do all the, you know, the brain work, if you like. So what I would say is that when a high income setting researcher does the secondary analysis from data collected in low income settings, as far as possible, they should involve the researcher that collected the data in the analysis, in understanding the data. And that also means that there is sharing, there is capacity building. Also, it is really difficult to understand the context where the data is collected if you haven't actually been on the ground to collect the data. It's a win-win situation for people who the secondary data analysis person to collaborate closely with the primary data collectors. And then the final thing is that when data is transferred to the data requester, there is an agreement that protects both sides. So that in the agreement, it will specify things like, you know, collaboration, and if the collaboration is meaningful and meets the criteria for authorship, then authors from the primary study should be included. So that's me. Thank you.
Thank you, Peg-Yong. I've got a nice short one for Cynthia, who appears to have the world record in the number of ethics committees she's proposed to. It says, how can we incentivize ethics committees to rapidly process submissions during a pandemic? Sticks or carrots?
Oh, it's short, but it's difficult, right?
Yes.
I think that one of the main things we need is an understanding of the current situation. It's true that there might be limitations in terms of personnel or capacity, but if we understand how urgent the situation is, maybe we can try and find the solution. Is it more resources? Is it what it takes? And where do we have to go looking for those things? Maybe it is carrot and stick, but we need to first of all, talk to them and communicate, I think. Thank you.
Thanks, Cynthia.
Can I add something on this one?
Please do. Yes, Natalie, go on.
No, because I agree with you, but I think it's also political will. I mean, there needs to be, and I think what I've heard is that in some countries in the UK or in the US, for example, they've been looking at, they decided to do this and they had the capacity. It's both. You need capacity. But if you have the will and you have joint procedures which cover for lack of capacity or unequal, I would say it's not lack, but it's, you know, some agencies are very competent in one aspects of looking at the clinical trials, others have other capacities. By joining forces and having a higher level political will, and I don't know, maybe some colleagues on would like to say more on this, but it should be, you know, it should happen, it should be feasible. And in a pandemic like this, we can't just rely on the same systems because we know it doesn't work. I mean, we know that. So political will and joining forces could help.
Yes, I think it's a very important point because it's quite clear that bureaucracy has thrived under COVID, and bureaucracy disempowers low resource settings because it's expensive and difficult to overcome it. And I think this is a really serious and important issue. Okay, here's a good one. Where do you see, in fact, Natalie, you could take this one first anyway. Where do you see funding coming from for the development of potential global biobanks and increased sequencing capacity at local levels? By the way, perhaps you could first explain, you know, that the reason for this is to is so that there is, as John mentioned right at the beginning, we need early actionable intelligence on the emergence of, for example, vaccine-resistant mutants or drug-resistant mutants and so on. And that can come through the intelligence produced by knowing what the sequences are, rather like the intelligence that we get for influenza each year. So where's the money coming from, Natalie?
Oh, thank you, Nick. Very nice of you to ask me. No, I think GloPID-R is well positioned to address this. This is typically something that is related to preparedness and to pandemic, clearly. And the GloPID-R Plus, I don't know if GloPID-R includes all the big funders, but I mean, it has to be a joint. It's not only one sole founder that can do that, but a coalition of funders. And in fact, it's my one wish. So maybe I can be relieved from giving the one wish, because my one wish, if there is one, is that at the end of the meeting, there is a roadmap to develop this capacity to map what's existing, to map what's missing, and to have a plan and a roadmap to do biobanking and sequencing, increasing sequencing capacity for now and the future. That's my big wish for today.
Thanks. But I'll ask everybody else for their wishes too.
I know.
You've got away with it. Here's one, I think this could be for Pei Yong again. Important aspect of promoting research in LMICs is to make doing research sustainable. The cost of publishing is exponentially rising. How can we facilitate indigenous journals and publication houses that are open access, have modest publication fees with the support of funding agencies? Interesting.
Yeah, it's a very difficult one.
That's why I asked you.
If anybody, let me think about it. If there are any takers in the meantime, okay, I'll try. It is true that it is very expensive. And one thing that Dr. Ernie brought up is that LMIC researchers hardly ever have protected time for research. So I think one way of trying to bridge the gap is for governments or external agencies to give protected time for research. And I think Ernie has her hand up, so I'll pass it on to her.
Go ahead, Ernie.
Yeah, but actually I'm not going to talk about that one, but okay, so so since it's
but say what you were going to say anyway.
Okay, no, first, Prof, I would like to say that I'm also a clinician and I like to do research. So that is maybe why the Dean of the faculty put me as a chair of this research institute for infection and immunology, because I have a patient, I have clinical question, and I like to solve it. So that's the thing. But then it is true, it's very difficult for us maybe in Indonesia, where Dr. Peck is also works, to combine, because being a clinician is always more tempting, because you deal with patient, you finish it in that time, and that's it. You don't have to look for grant, you don't have to prepare protocols, don't have to think about how you collect data and so forth. But I think in Indonesia, we start to have people, we encourage, we see the potential, and also the Ministry of Education and Ministry of Health, they sit together and try to look on how this can be put as a motivation for these people like me, a physician. I'm an internist. I'm doing ID. I still can be involved in research while also doing my routines. But what I'm going to ask is actually something else, Prof. So due to the barriers that I already mentioned, actually there are some studies that been postponed. So the question is how patient is the sponsor actually can wait until we can solve. Like I say, I like to keep moving. So when there's something stop me, I just just move forward and try to solve it and smile to everybody until they say, oh, okay, you again. So okay, I will just give my sign, and then we can do the study. But then is there any way that the sponsor could, negotiate with us, or will say, okay, you only have 1 year, otherwise we are going to move to another countries or something like that? That's actually the one I'm going to ask. Thank you.
Thanks. I don't know who we're going to ask that to, but we could perhaps combine that with the last question. I don't know if I'm allowed to ask Alice and Amelia, but we have got several people who wanted questions for them. So as you are involved in supervising, at least indirectly, research, how generous should research funders be in understanding the difficulties created by COVID in conducting research, and how generous should they be in allowing people some flexibility? And here's another one. It says sharing research data, ! It requires sending information. It takes time in a world where everybody's in a hurry. How do we incentivize this extra activity for researchers? And I know that the funders strongly encourage it, but how should they incentivize it? Can I give that one to Alice and Amelia? Is that, if that's not unfair? As well as responding to Ernie.
Thanks, Nick, for that. It's Alice here. So I'll respond in terms of what we've seen in terms of the work we've seen from UKCDR and GloPID-R on this. In terms of how generous should researchers be around research plans changing around COVID, I think it's something that we have seen many instances of in our funding tracker, is essentially where pre-existing grants have either been repurposed or supplemented or paused or such like, either because they have wanted to shift to undertaking research on COVID, or because of issues with undertaking the research that they wanted to do that was nothing to do with COVID. So I think, it's quite clear that many research funders have been taking that seriously, and clearly that's raised as a core issue. In terms of data sharing, and what research funders can do to support or incentivize that, again, the GloPID-R group of research funders have a specific data sharing working group and a data sharing working roadmap through which they are trying to look at ways to support this further. There have been a few particular initiatives that I'm aware of personally that have been funded to support data sharing during this pandemic, ICODA being one of them. But it's quite clear that, to me, that this is a persistent systems issue that is coming up, that funders are paying attention to, but I would certainly agree more attention needs to be paid to, and it would be great to hear more in this meeting about the barriers to that, because we're bringing here funders and researchers together to hear about what's still not working in that area, and it's quite clear there's need for further support. Was there something I missed? Anything else?
No, that's fine. That's fine. Thanks very much, Alice. So I'm just going to go around the panel quickly for their one wish. John, one wish.
No, thank you very much, Nick. I'm having a bit of internet trouble, so I hope you can hear me. The one wish that I would have would be for funding to support clinical research in LMICs to really focus as much as possible on the integration of the health care delivery system and the clinical research system. I think this would be a game changer.
Thank you, John. Ernie, one wish.
Okay, bro. I wish the implementation of One Health concept, so it's not only about COVID. COVID might be just the trigger, could be implemented and should not just be an idea. So One Health is, I think, what we should approach. We start from COVID-19's situation now.
Thanks. Cynthia?
Well, one long wish, joint efforts and better timelines, please. from RAs and ethics committees.
Right. We can't ask Philippe because he's not with us. Peg Yong.
Okay, so the one wish I have is for funders of funding to take seriously the cost of data management and sharing. So data management and sharing means you need a data management team who's skilled with expertise, with the software that is needed. And then we need to also remember that data management and sharing doesn't end when the study finishes. So for instance, we have data sets that we finished 2005 and we're still servicing these data sharing requests. So a lot of effort and time needs to go into servicing this request, correspondence, answering questions, etc. It takes time and effort. That's me.
Thanks, Peg Yong. Esther Vale.
So I think I would take one as my special request, investment and a tool, and a special tool to make all of our low and middle income countries to work together to raise our own questions and to find our own responses to this the great challenge that this COVID-19 represents to our health systems. So that we can collaborate together, raising our own questions.
Thank you. Natalie's had hers. So lastly, Madia.
Can I have another one, maybe?
Oh, all right then. Nadia, I apologize. Nadia,
No, it's
Natalie's rather
because,
greedy.
no,
Go
I'm
on
sorry.
then.
No, I'm sorry. It's because I'm not sure I reflected what the coalition said, and I want to be fair on all those working groups who did highlight the need to do some research in maternal health and make sure we understand the impact of COVID, and everything we do includes the fact that we may include young women who may become pregnant during the treatment and what will happen to them and what are the treatment solutions that they can take whilst being pregnant, not to forget that, and support those studies. Thank you, that's it.
Thanks. Madia?
Okay, so during this pandemic, we have seen a huge disparity between high-income countries and low-income countries in terms of incidence and mortality. Like from Pakistan, it's a huge country, 200 million. We have seen only 654,000 COVID patients with only 14,000 deaths. So I would like the funding agencies to look into the host genetic variants, that what is different. Because generally speaking, I think the living conditions are worse in LMICs, but somehow COVID has not hit us as badly as the Western countries. So something about host genetic, the capability is not developed in low middle income countries. So a lot of funds are required to build capacity and train people to carry out these kind of research projects. Thank you.
Thanks, Madia. And it's only fair that I ask my co-chair, Jean-Marie, if he has a wish.
Yeah, my wish is to be informed by the researchers. I represent the funding agency, and sometimes it's easy to say that we can solve the questions by launching calls for proposals, by funding as much as good as we can. But what we have seen in the past year, we've done our best to put money on the table quickly, and research was initiated at the time compared to previous streams when we were not facing a pandemic as the one we are in right now. So my wish is just to have this dialogue not stopping in just one webinar, to keep getting feedback from the research community about what we, the funders, can do to enable research to provide the answers as quick as we can. Not that community waiting for us to launch our standard calls or our own imagined calls, but to have this continuous feedback. Never stop sending your messages and your emails and your requests, whether you do it through these kind of settings or through another channel via your own consortia or in coalitions or in other international groups that you participate in. That is my wish as in my position as a representative of representative of funding agency. Thank you.
Thank you very much, Jean-Marie. And I'm going to have a wish too. Natalie has already given the priorities from the coalition. I've got two wishes, so I'm going to be greedy. Number one, I think we should study bureaucracy as a disease. But number two, I'm very worried about the falsified and substandard medicines, fake vaccines, substandard drugs. And this is a particular problem for low resource settings, and it really does need some research. So with that, I really would like to thank again my co-chair. Thanks to all our speakers and the panelists and the questioners too. And I hope this has illustrated some of the current obstacles to conducting research in low resource settings and how they might be addressed, and also the enthusiasm to address this. So now we must move into the next session. That's on health systems and the indirect health impacts of COVID-19. And for this, I pass you to my colleagues, Dr. Moses Alobo from the African Academy of Sciences in Kenya, and Professor Patricia Garcia from the Cayetano Heredia University in Peru, who's also a member of the COVID-19 Clinical Research Coalition Steering Committee. Thank you very much.
Good morning, good evening, all of you. My name is Moses Alobo from the AISA platform at the African Academy of Sciences. And for this particular session, for the next probably 1.5 hours, me together with my colleague, Professor Patricia Garcia, are going to take you through several very interesting discussions on health systems and indirect health impacts of COVID-19 and the pandemic that we are currently in. This is particularly important for the simple reason that when you think about health systems, it's usually very easy to just concentrate on vertical programs, especially in low and middle income countries. And there is a point in actually thinking about all the other aspects, components, elements that form the full health systems. From the beginning of this particular pandemic, there were concerns that were expressed that regardless of income levels, there are going to be effects of the COVID pandemic, both direct and indirect. Indeed, some health parameters, indicators have actually changed within countries with some dire consequences on not just the health systems themselves, but also the population health has been affected. So there was a prediction at the beginning of this particular pandemic that there will be a collapse of the health system. And this applied not just to low and middle income countries, but also to high income countries. And of course, this brought about the discussion around flattening the curve, and also a real push on non-pharmacological interventions, of course, especially focusing on social distancing. And as you can imagine, social distancing and everything else has led to lower utilization of health systems within low and middle income countries. So the impact of these limitations and shutdowns and all the other government policies that we've been following has had an impact on, of course, limiting movement, but also in terms of health on EPI, the routine infant and child vaccination programs, access to antenatal care, infectious diseases, of course, and non-communicable diseases screening and diagnosis. We've seen elective surgeries going down. We've seen access and also surgery calls for cancer treatment and chemotherapy also going down. So there are definitely many gaps in the data for evaluating these indirect and long-term health and health system impacts. And we think that at the beginning of this particular pandemic, there were questions around, are we going to be seeing excess mortality, not just from COVID-19, but from other aspects because of the impacts of COVID-19. And yet the data has come through in some regions, but in some regions it has not yet come through. So we thought that this particular session, we would have a discussion on the impacts of the pandemic and public health interventions on health systems and also public health, not just focusing on infectious diseases alone, but also considering non-communicable diseases, vaccines access, our attitudes, health workers, health financing, and everything else that we need to discuss. And to assist me chair the session, as I'd said before, is Professor Patricia Garcia from Cayetano Heredia University in Peru. And she's also a steering committee member of the COVID-19 Research Coalition. So over to you, Patty.
Thank you so much, Moses. As Moses said, there are more questions than answers on the impact of the pandemic on the public health and health systems, and even more questions on what we could have done better and what can we learn for the next pandemic. A modeling paper published in the Lancet Global Health in May last year provided early estimates of the indirect effects of the pandemic on maternal and child mortality in LMICs, estimating up to 1.1 million additional child deaths and at least 60,000 additional maternal deaths over 6 months, everything associated with a routine healthcare disruption. But it has been more than 6 months, and we still have disruptions in our health systems and so many gaps in information about what is happening, not only in maternal and child health, but also on non-communicable diseases, cancer treatment, and we need to know what is going on. The Latin American and Caribbean Consortium on Dementia, for example, has been tracking the impact on COVID-19 on dementia, and results are really terrible. So today we are going to have presentations from 4 experts in their fields, ranging from medical anthropology and epidemiology to regional level policy guidance and maternal, newborn, and child health. And we hope also to have a discussion on what has been seen, what could have been done differently, what are the kind of things that we still need to measure, and what is the type of research that we really need to implement to improve what is going on, to try to fill the gaps, and to try to do it better for the future. So these presentations the ones that will follow will take about 5 minutes, but we hope that they will be passionate and also with a lot of information in them, and they will be followed by a panel discussion and a session of questions. During the presentations, please, I would like to ask all the participants to post their questions in the Q&A box and upvote other people's questions by clicking the thumbs up. So that's something that has been used in the previous session too, so please try to do that. So it is my pleasure to introduce the first speaker. The first speaker will be Professor Sabina Rashid. She is the Dean at the School of Public Health of Brak University in Dhaka, Bangladesh. And she will talk about the impact of COVID in the most vulnerable in Bangladesh.
So good morning, good evening, good afternoon, wherever you are. I'm representing the SONA Global Consortium Partnership. I'm with the James P. Grant School of Public Health at Brak University. So the main thing about SONA Global and one of the critical impacts of SONA Global will be for pandemics future and currently is the vulnerability assessments and community engagement. As we know, many, many vulnerable groups, disadvantaged populations have been affected globally in Bangladesh and elsewhere with varying sort of, and also surprising impacts in more developed countries. But either way, the SONA Global Consortium has been conducting vulnerability assessments and engagements in Bangladesh, Uganda, France, Germany, Italy, Slovenia, and Malta. Why vulnerability assessments and why communities? I think it's most important to remember communities are heterogeneous. Populations are heterogeneous. So they come from diverse socioeconomic backgrounds and intersectional factors, which is geographical location, age, religion, ethnicity, class, socioeconomic status, poverty, where you are in the poverty sort of hierarchy, have huge impacts on your experiences of COVID. So the objectives of this vulnerability assessments, which have begun with communities, and not just token communities, working with communities to find out sort of these spaces that, and how they understand vulnerabilities, to really understand systematically qualitative and potentially scalable data that can help us understand what are the different causes that really impact to exacerbate vulnerabilities. We do know that a holistic and a comprehensive approach is very important and does justice to understanding. And then I think it's very important to understand, because it's directly related to, okay, I will speak slowly. I just think I have 5 minutes in my head, so then please be flexible. So I think what's important to understand is if we don't understand the complexities of the social, the economic, the personal, the physical, in people's lives, particularly vulnerable groups, and particularly during lockdowns where entire industries shut down, businesses shut down, schools shut down, transport shut down. There are huge impacts socially, economically, and personally, physical risks, and you'll find out a little bit more about indirect health systems risks. One thing is very important to understand, not a top-down approach, but how do these people who are living these fragile lives, because they were already poor, COVID just magnified the inequalities and inequities. How do they categorize themselves? How do they understand their lived experiences so they can engage and give feedback and actually be part of the stakeholder discussions on how do we respond to this pandemic, which is still going on. In fact, Bangladesh, the cases are rising again. And I think the critical issue for Sonar Global is not just to do research for the sake of it, but to do research that informs evidence, to work closely with stakeholders, to influence policies, but also to support and create space for these marginalized populations. Next slide, thank you. So we are using Bangladesh as a case study. The first infection happened in March. By 24th March, Bangladesh declared the country's lockdown. This was followed by many other countries or sort of mimicking other countries. The difference is Bangladesh has poorer social safety nets, much more densely populated. Contexts are very, very different, where millions lost their lives as garment factories shut down, educational institutions shut down. There was no transport. Everything was completely in a complete standstill. We are already dealing with a weak health system, poor governance, corruption, weak communication, and increased strain on existing systems and trust. If you look at the history and the political economy, history is very important. Initial test interviews found hunger, employment, and the struggle of dealing with COVID and will I die? Are we at risk? And where are we going to eat? What are we going to eat? Where are we going to get the money? Food insecurity, health risks. Healthcare costs had gone up. Even food prices had gone up. Occupational risks of infections. People risked, particularly the poorest. They didn't have the luxury of sitting like me in my room doing Zoom calls on the streets, going back to the factories as soon as everything opened up in June. A huge problem was communication. It was very biomedical, led by a clinician task force, for the language was quarantine isolation. This resulted in low uptake of services because people were scared what would happen in quarantine isolation, if they would ever see their family again, whether they would die in the hospitals. Huge amounts of mental stress. And people talked a lot about losing their networks. So stigma and absence of a support mechanism during those 4 or 5 months has been huge, particularly for vulnerable populations, but depression and the struggles of COVID has hit across all socioeconomic classes. As one said, we cannot afford sickness, because they're already living a life of debt and fragility, and only God can save us. I just wanted to say two quick things, because I only have one more slide, which is if you look at vulnerability assessments, they identify those who are already getting even further marginalized. Adolescent street hawkers, if you're below 18, don't get ID cards, which means you cannot sign up for relief materials. People who are disabled did not have mobility, did not have information where to collect stipends. Pregnant mothers had delayed access to services, and newborns had delayed access to vaccines. So finally, I think what we're talking about is that if we don't, more than ever, create resilient health systems, this is not the last pandemic. It's going to continue. As I said, cases are on the rise. We really need evidence. Evidence is critically important beyond the surveys and the clinical sort of diagnosis. We need to identify contexts and situations about those who are the most marginalized, who live in structural inequalities and poverty, and work with key stakeholders. In Bangladesh, you've got many, many active stakeholders, and often they don't have the evidence to work in coordination. Community engagement is critical. It has to be bottom up. Often communities are pragmatic. Bangladesh has a public health history of community engagement, which is inclusive. And that's how we've tackled diarrhea, TB, and other forms of diseases across the country. So a lot of people wrote last year about how do we have a more inclusive approach rather than just a clinician task force approach. Currently, there remains a lack of coordination amongst focal agencies, but we are hopeful that with evidence and vulnerability assessments, we can actually start the steps towards creating a resilient health system. Finally, public health needs to be unpacked. It's not biomedical. For the most vulnerable, it's disease, it's physical, it's economic, it's social, and context matter. Final slide, I just want to thank our funding donors. Thank you very much to the European Union, and thank you to my colleagues and team members. Thank you very much.
Thank you so much, Professor Sabina Rashid, for that very precise presentation. And I think I agree with you that vulnerability assessments and community engagement are very important for the simple reason that everyone usually does a self-assessment, and the self-assessment according to their circumstances is what leads them to either choose certain health prevention interventions or even change their health-seeking behavior. And of course, health systems that are resilient to COVID-19 and also can be able to take care of the vulnerable become really and truly important. So thanks again for that. So I am happy and privileged to introduce our next speaker. Our next speaker is Professor Yap Boum II. Professor Yap Boum works with the research arm of MSF, Médecins Sans Frontières, epicenter in Yaoundé, Cameroon. He's got expert understanding in, of course, TB, malaria, Ebola in the context of public health systems delivery, and is also currently doing some work with the COVAX that is delivering vaccine to many parts of low and middle income countries. So Professor Yap Boum, over to you.
Ok, donc je suis content de pouvoir m'exprimer en français et je remercie les organisateurs d'avoir permis d'avoir cette traduction permettant aux divers chercheurs de pouvoir s'exprimer, mais surtout avoir l'information dans la langue de leur choix. Ça a été mentionné, je crois, par Peter Piot, qui relatait le fait que la langue reste quand même une barrière, surtout en Afrique, pour pas mal de chercheurs. Slide, please. Donc, je vais mettre en avant dans les 5 minutes qui me sont allouées. Prochaine slide. Diapositive. Donc, rappelez qu'aujourd'hui, je suis basé à Yaoundé, en Afrique, où nous avons cette seconde vague de Covid. Cette seconde vague qui a été mentionnée, je me rappelle quand Dr. Kangasong passait par le Cameroun, c'était déjà en octobre, novembre de l'année dernière. On voyait déjà les signes avant-coureurs de cette vague. Et malheureusement, très peu de pays africains l'ont prise à bras le corps, comme ils l'avaient pourtant fait lors de la première vague en termes de préparation. Ils ont, dans cet article qui est paru la semaine dernière dans le Lancet Infectious Disease, mis en avant la diversité de l'épidémie, de l'impact de l'épidémie dans les 54 pays africains, que ce soit en termes de nombre de cas, que ce soit en termes de nombre de décès, mais également dans les approches par rapport à la réponse. On va parler des tests diagnostiques, on va parler des stratégies en termes de confinement et de réponse politique à cette pandémie. Et ce qui est mis en avant, effectivement, c'est que cette diversité d'impact appelle également à une diversité en termes de réponses. Donc, il faut penser à des réponses qui soient spécifiques par rapport au pays, en fonction de l'impact de l'épidémie, en fonction de l'infrastructure qui est disponible, mais également en fonction des autres maladies qui déjà affectent les pays dans les pays africains. Il y a eu beaucoup d'impacts. Il continue à y avoir pas mal d'impacts de la COVID en Afrique. Il y a des impacts positifs. Au début de la pandémie, seuls 2 laboratoires au Sénégal et en Afrique du Sud étaient capables de pouvoir diagnostiquer la COVID en Afrique. C'était au mois de février. Aujourd'hui, quasiment tous les pays africains, en tout cas les 46 pays qui sont membres de l'Union africaine, sont capables, ont les capacités, même si elles ne sont pas suffisantes, de pouvoir détecter la COVID par PCR. Maintenant, il y a également eu la possibilité d'évaluer les tests de diagnostic rapide pour avoir des algorithmes qui soient plus pertinents pour la logistique, pour les difficultés, les contraintes que pas mal de pays africains subissent. Donc ça, ce sont quelques impacts directs. Maintenant, les impacts indirects plutôt négatifs, on pense bien sûr aux maladies que sont le paludisme, dont les campagnes de dons de moustiquaires imprégnés ont dû être abandonnées, les sensibilisations également. On pense également à la rougeole, dont les campagnes de vaccination supplémentaires ont été mises en stand-by à cause de la COVID. On pense également à des pathologies comme la tuberculose, pour lesquelles nous n'avons pas encore suffisamment de données. Epicentre mène actuellement au Malawi une étude pour voir l'impact de la COVID sur la tuberculose, mais ce genre d'études, que ce soit sur le palu, sur la rougeole, sur les maladies diarrhéiques et autres, sont importants pour permettre aux pays, de manière vraiment spécifique, de trouver les solutions par rapport à l'impact de la COVID dans leur environnement. Prochaine slide, diapositive. Maintenant, il y a effectivement des pistes de recherche qui sont importantes. On a parlé des variants. Le variant est véritablement l'un des mots nouveaux que la majeure partie de la population a appris pendant cette pandémie. Par contre, les possibilités de le faire ne sont pas suffisamment importantes. Donc, il faudrait pouvoir démocratiser dans l'ensemble des pays qui puissent avoir cette capacité de faire cette surveillance et donc de voir dans quelle mesure on pourra adapter les stratégies que sont par exemple la vaccination. Maintenant, c'est important pour moi de rappeler le challenge de la résistance aux antimicrobiens. L'azithromycine, par exemple, a été déployée dans la majeure partie des pays africains dans la lutte contre la COVID, que les personnes soient positives ou négatives en prévention ou en traitement. Donc, on peut quand même s'attendre à avoir des impacts plus tard. Donc, il est important d'avoir des évidences qui puissent le confirmer. Maintenant, pour ce qui est de la vaccination, premièrement, il faut qu'elle soit spécifique par rapport au pays, d'une part, et d'autre part, on voit qu'il y a des hésitations en fonction des pays. Maintenant, pour conclure, prochaine slide, il est important de dire que les financements doivent venir d'ailleurs, mais surtout d'Afrique. Il y a aujourd'hui en Afrique un nombre important de milliardaires qui peuvent contribuer, comme on l'a vu d'ailleurs au Nigeria. Je pense que c'est un bel exemple aujourd'hui de la réponse à la COVID avec l'implication des philanthropes et du secteur privé. Donc, c'est un bel exemple. On a vu aussi MTN, par exemple, qui accompagne les pays dans l'achat des vaccins. Je pense qu'il y a des opportunités ici de pouvoir créer des consortiums, de les renforcer public-privé, non seulement pour la réponse, mais également et plus spécifiquement pour la recherche, afin de permettre aux pays de pouvoir respecter cette convention d'Abuja qui disait que les pays mettraient un pourcentage de 10% de leur GDP dans la recherche. Prochaine slide. Next slide. Donc, pour terminer, pour rétablir une certaine équité, il y a des sujets sur lesquels on doit travailler. La surveillance génomique, bien sûr, les séroprévalences qui nous permettront d'évaluer à quel point chaque pays, de manière spécifique, se trouve par rapport à une immunité collective qui elle-même est challengée par les questions de variants. Il y a aussi en Afrique les questions de médecine traditionnelle. On n'a jamais autant utilisé les médecines traditionnelles dans le cadre de la COVID. Mais quelle est leur véritable efficacité? On a besoin également d'utiliser les codes d'essais cliniques que nous avons pour d'autres vaccins, d'autres médicaments, appliqués à ces médecines traditionnelles. Et enfin, la santé mentale, qui est pour nous, en tout cas, l'une des révélations, si on peut le dire ainsi, de la COVID. Donc, c'est vraiment un coup du cœur pour les financements, mais surtout les Africains eux-mêmes, de prendre davantage nos responsabilités afin de trouver des solutions qui sont propres à nos pays. Merci.
Many thanks to Professor Poom for his presentation. And thank you for doing it in English, in French, I mean. So there was a comment before, with the translation, we were going to have presenters speaking in French. So we do. We're trying to be really global here. So it's great that you highlighted at the beginning that although this has been a terrible pandemic, in certain areas like Africa, and I envy that, to tell you the truth, I mean, it's a good envy coming from Latin America, you have been able to, for example, take this as an opportunity and improve the capabilities of the laboratories. But still, you have highlighted also that there are still challenges because there had diseases like tuberculosis, malaria, measles, mental health that probably we have left without, and we know that we are going to have some delays because of the COVID pandemic that has not allowed us to do much on those areas, and the importance of integration of health services for the future. So thank you so much. So now let me introduce to Dr. Massimo Girinelli, who is a public health expert with extensive experience in infectious diseases and now leads the unit for HIV, hepatitis, tuberculosis, and STIs, and the Pan American Health Organization Initiative for Disease Elimination. He will talk about the impact on the pandemic, on prevention, treatment, and care of other infectious diseases other than COVID in Latin America. Welcome, Dr. Girinelli. The floor is yours.
Thank you very much, Patty. Thank you, Moses. Thanks to the organizers for the invite and for the opportunity to share an overview on Latin America and the Caribbean from the viewpoint of several public health priority programs. And I must say, vertical programs that have slowly, gradually began to operate in a more integrated manner, in a more integrated approach. And certainly public health programs that have embraced in the last few years the goals and the perspectives of elimination by the year 2030. Next slide, please. The first dimension I would like to explore in this short overview is about the economic impact of the COVID pandemic. Can you click, please? Maybe there's some hidden animation here. Again, this is data and estimates that have been developed jointly by my organization together with the UN Economic Commission for the region of the Americas. And on both sides, you see the impact, estimated impact on GNP as a rough indicator of wealth, and also the impact on the contrasting poverty in the region. Both are heavily impacted by the pandemic and probably are expected to push back the gains of the region in an excess of 10 or even up to 14 years if comparing the trajectory of both parameters being mentioned. This is extremely important because we are operating in a region of extreme inequity and profound maldistribution of wealth. And the sad expectation is that these impacts on social determinants of health will be eventually felt the most by those very vulnerable populations who are also mainly and primarily affected these very pandemics, these very epidemics I was mentioning. Next slide, please. Another dimension I would like to explore is the impact on mortality and morbidity. We do have global estimates. We don't have really disaggregated data by region, but I look at this work of Philippe Glasieux on TB parameters, and you can see there's a pushback in terms of case detection capability estimated by the year 2020 in the excess of 17–18%. And also there's an estimate of excess mortality in the order of 500,000 for the year 2020, pushing back the response to TB to the level where we were collectively around 2010. So again, once again, pushing back the gains for about a decade. Next slide, please. Selected HIV indicators, they all indicate a profound pushback in terms of number of testing, particularly in the first semester of last year. We have also observed a certain rebound in the second part of the year, but the same trend applies to the number of new diagnoses, HIV diagnoses, but also in the number of new entries in the provision of antiretroviral therapy, life-saving therapies, chronic therapy, and finally a decline in the number of viral load tests executed as a part of a monitoring of the chronic antiretroviral therapy for people living with HIV. Next, please. So even the very highly protected area of PNTCT, prevention of mother-to-child transmission of HIV, which in Latin America and the Caribbean goes hand in hand with the prevention of syphilis. Even this area, which is extremely protected because it is probably the most integrated into maternal and child health care settings, even this area is showing, according to data collected last year, some signs of deterioration and decline. Next slide, please. This is from the TB. If you can click further, please. Again, the hidden and all right, great. There's a wide range of impact in terms of year by year 2020 data over 2019 data in terms of case detection of new cases of TB, from minimum impact to an almost 40% reduction, which confirms the global estimates and indicates probably in around 16–17% the mean impact on the capability of health systems to capture new cases of tuberculosis. Next slide, please. Very similar situation on hepatitis, for which we have relatively few data available. This comes from the Coalition for Global Hepatitis Elimination. It's a small-scale survey conducted among providers of hepatitis C services, and the majority of them indicated a profound impact in terms of reduction in the screening activities for hepatitis C, particularly during the months of the highest impact, lockdown and social distancing measures, but also the similar profile, a similar pattern in terms of provision of hepatitis C treatment. Next slide, please. I'm ending my presentation with a reminder. One of the most successful measures for mitigating the impact of the pandemic has been the multi-month dispensing of ARV drugs. Definitely a good development of existing policies, moving away from restrictive supplies of medicines for 1 month to a more liberal and more generous supply up to 3 months, and at the same time resorting also to distribution through community mechanisms. Next slide, please. This is my final contribution. I just listed 4 topics among the very many that came to mind in terms of investing on operations research and contributing to the development of evidence and data to inform the transition to the post-COVID phase of health systems. I thank you very much again for your attention.
Thank you so much, Massimo, for that brilliant presentation. And I absolutely agree with you, Massimo, that definitely there's a vertical program developing around COVID-19, just like we've seen in any, many of the other interventions so far in low and middle income countries. The question is how to basically integrate what we are seeing in an effort to make sure that the other areas, the other health indicators are also not left behind. And it's also important to just underline what you said about they've been a pushback on some of the health indicators for TB, for malaria, with very little data in other areas. So of course, more work needs to be done. So thanks again for that. All right then, so it is my pleasure to invite a good friend and colleague, Dr. Queen Dube. Queen is from Ministry of Health in Malawi and works at Queen Elizabeth Central Hospital, the largest tertiary hospital in Malawi. She's a neonatologist by training with lots of research interests in MNCH, neonatal sepsis, KMC motherhood, point of care diagnostics, for example, and was also a co-PI with the NEST 360 clinical trials, which looked at neonatal mortality in Africa. Of course, with lots of extensive experience and extensive publications on these topics that I've just mentioned. So it will be nice to hear from you, Queen, about MNCH in light of the COVID-19 pandemic. Over to you, Queen.
Thank you, Moses. I'll talk about the impact of COVID-19 at the health systems here in Malawi, but also touch a little bit on how we're using community health workers in the rollout of the COVID-19 vaccine, but also to deal with issues around vaccine hesitancy and access. Next slide. So just a little bit of background. December 2019, we heard of the first case of COVID-19 in China. For Malawi, we declared a state of disaster on the 20th of March, 2020. And a few days after that, we had our first COVID-19 case. It's quite a lot of nervousness in the system and a lot of fear. And so we had our first wave around about end of April to July time. And then the number of cases really dwindled to an extent that almost all our isolation centers and COVID facilities were closed down. And we thought we were done with COVID, only for it to resurface in December last year. And things really peaked in January and February time. We've started to see a downward slope in the number of cases due to the second wave. And so as was experienced with a lot of countries with the first wave, there was a lot of fear. Our systems were not prepared. Initially, we thought maybe it's something like bird flu that we want to be badly hit. So systems were not really prepared. And so a lot of what we did in the first wave was a lot of firefighting. We need PPE. Where do we get this? Do we have to close down some services? Do we need to continue with just emergency sections? And remember, there was even a deep discussion around, do we continue with our routine immunization programs? We do a lot of outreach immunization programs, and sometimes people can be crammed at one place. So there's a lot of debate on what needed to stop, what needed to continue. Fortunately, the first wave didn't take a long period of time, and we didn't have too many cases. If you move on to the next slide, please. So, as of about a week ago, we had 33,270 cases, predominantly young, a current age of 34. But in terms of those with severe disease, the bulk of them were actually older people, at least a median age of 60 years of age. Next slide. Now, one of the things that we learned after the first wave, the 2-3 months we had as a time when we reflected and we had very, very, very few cases on the ground, was to really have a systems approach to this whole thing. And so there was a lot of thinking through around the health system building blocks. What is it that needed to be done around service delivery, human resource, leadership and governance, the health information system, financing, and medicines and technologies. So we decided to do this to leverage on the COVID-19 pandemic because there was a lot of resource mobilization. There was a lot of will from the donor agencies to put in a lot of money towards a COVID response. And as a country, we thought, why can't we use this to strengthen the whole system? And so over the past couple of weeks, we have hired a lot more nurses, a lot more midwives, a lot more doctors and other cadres that work within the health system, plus the community health workers. We have procured more equipment. We have been able to put in place 2 oxygen plants within a space of 2-3 months. And there's a 3rd plant in the pipeline. So when you look at all these things, they just don't tackle COVID. It spans across the whole health system. And we think that maternal and newborn health will benefit a lot with the medicines and the technologies that have been bought and they've been put in place. And the other thing that we also did that is not part and parcel of the health system building blocks is to strengthen local innovation and capacity. So we had our engineering schools actually developing technologies that we're now using in the routine system. Just 1 minute to talk about what our community health workers are doing. Next slide, please. Next slide. So we started our vaccination program on the 11th of March, 2021. As we speak now, we are a third. We've used a third of the vaccines that we have in country. Next slide. And we had a plan to target our frontline health workers first. And so we've been able to cover at least 50% of our frontline health workers. We've opened it up to people with underlying comorbidities, people that are over the age of 60, and other frontline social workers. Now, the biggest challenge that we are encountering at the moment is the negativity, the negative publicity that we had in country from around about the month of January till now, around about the COVID-19 pandemic, but also the vaccines. Surprisingly, in the urban settings, people have turned around. We are actually overwhelmed. But now a lot of work needs to be done in the rural areas, where now we are engaging community health workers. They have a 1-day quick orientation on community engagement, vaccination, following up adverse events, following immunization, working side by side with our nurses. We do have a huge challenge with our a number of health workers on the ground. So for things like immunizations, over time, for decades now, Malawi heavily relies on these community health workers. And it's amazing that even with the e-registration system, they're actually able to do it. So we're able to track things using real-time data. We hope that some of the lessons that we've learned from introduction of the vaccination program can actually be used in other programs for maternal and newborn health. So one last word, we need a lot of implementation research that tackles health systems for countries like Malawi to learn from. Thank you.
Thank you so much, Dr. Dupe, for bringing this very positive view and great examples of what Malawi is doing and how in the middle of this crisis, you're using the crisis as an opportunity to strengthen capacities of the health systems. So it has been, first of all, I would like to invite all the presenters to turn on their cameras for the panel discussion. I would like also to ask all the participants to use the box to post their questions. I have seen relatively a few questions compared with the previous session. And I wonder if what happened is that we are still really focused on COVID. And when we start talking about what we could call the indirect effects of COVID, we don't pay that much attention still to that. But it is quite interesting. And from the discussion that we have had, we can see that definitely all this attention that has gone into COVID has caused definitely a big problem that we are going to start seeing now. And for several years, we have seen from Africa and from Latin America that we're concerned about all the other diseases that have not been taken care during this time because people had been at home, because the health services had not been working fully. I'm surprised that, for example, in Africa, primary health care has been open, but I can tell you, I can share that in my country, in Peru, the first thing that was completely shut down was primary health care, which was, I think, a real error. So everything was pushed into hospitals, and that really caused a huge problem that we have not been able to really handle up to this point. But we have also heard that there are some opportunities, and I would like to go into that and start this conversation with our panelists about innovations. I mean, if you know about the kind of innovations that had happened in your countries regarding offering services that relate to health systems, really. Massimo mentioned that there is a need to highlight, for example, what has been done with telemedicine, or maybe other innovations that had happened. So I would like to start by asking the panelists about innovations that they have heard, the use of telemedicine, has it been implemented, has it worked? Or innovations regarding new ways of testing. And these are issues that we need to start talking. I mean, self-care, self-initiated innovations, are self-initiated care. Are those the kind of things that had been started? Are those the kind of things that should become research priorities? Should we start collecting information and learn some lessons? So maybe I should start from Professor Sabina Rashid.
Hi, thank you. You know, Bangladesh is a place of, I would say, with the government and BRAC, where I used to work before I joined the School of Public Health, a space for lots of interesting innovations. But it depends on how you define innovations, because sometimes some of the simplest solutions have been co-created by communities. So if you look at innovations, our first diarrhea to combat diarrheal diseases, or the innovations around tackling crisis. COVID is a humanitarian crisis of huge proportions, right? And in Bangladesh, we have a history of health systems where we have the public sector or the NGO sector working closely with the informal sector, drug sellers, for referrals, for dealing with tuberculosis, for becoming information, communication, messaging spaces for communities to then go from one facility to another. And I wanted to say innovation is also, for me, if I look at it, there's many success stories, there's also many challenges, right? But I think Bangladesh itself, one of the key innovations was to be inclusive of communities, recognizing that 80% go to drug sellers. So that's the reality. Even I would go to a pharmacy, a local pharmacy somewhere, then wait in line for a couple of hours in a hospital if I need medicines. So if we're going to look at COVID, I mean, one of the ways is getting more sort of socio-cultural aspects into our risk communications. and empowering drug sellers and the other cares or the popular kinds of providers to become the ambassadors of communications for communities if we're trying to increase uptake of services. It's not just about digital technologies, but I would have to say the national rollout of the vaccine used a very simple SMS digital kind of registration system that the most vulnerable, poor groups could access. The challenge is the uptake is low because there's still fear and stigma around vaccination. So, this requires a when we look at health services as just service, I'll shut up in about a minute, but if you look at health services, only services, and somehow magically access will happen, I think that's the problem. We have to look at the human dimension and the factors that impact on why people may go to a particular service, which is informed by trust, it's informed by familiarity, it's informed by what are the other information sources they get. So I think we really need to look at it a little bit more critically. Otherwise, it's back to what do health services do? And somehow everything's going to become a panacea and somehow it's resolved. And we can see it with COVID. The stigma, the communications, even in the US. Huge challenges with mask wearing and non-mask wearing, and many other countries. Bangladesh, low uptake of vaccines, but huge, a very successful rollout program using innovations. Okay, thank you.
Thank you. Any of the other speakers, maybe Dr. Massimo, innovations?
So a few thoughts on innovation. I think certainly innovation has been one of the elements to mitigate the impact of COVID. And I think you have already mentioned the extensive use of telemedicine, not only to reduce the number of visits wherever facilities are kept open, but also to reduce eventually the crowding, to counterbalance a little bit the impact on transportation and the limited social mobility that the pandemic has imposed on societies. Certainly a big advantage in the region has been the existence of a vibrant HIV community, less so for the TB, but we see promising signs of waking up even in the TB environment, and so is for hepatitis. So no doubts that civil society has a great role to play. And I think we begin to understand the potential right now that we are confronted with the emergency of COVID. We knew that all, but that knowledge of the potential of community involvement has been heavily confined within the boundaries of vertical programs. It's a fact, and we all know the engagement of civil society and the activism in shaping up HIV policies and the impact that eventually had been generated in the response to the epidemic. I do hope the same level of attention will be paid to rethink community involvement over a wider range of topics that really can embrace the large majority of public health challenges. Then technology can also help in terms of bringing and accelerating the transition and the introduction, the registration, and the use of technologies that are already available. I'm thinking about HIV self-testing. I'm thinking about the newcomer in terms of hepatitis auto-test. These are technologies that decentralize the use of laboratory, that relieve the burden over overcrowded and overburdened laboratory facilities, and again, engage communities and increase the individual responsibility vis-a-vis communicable diseases. Other areas of improvement where innovation can help is definitely the sense of urgency in transitioning and accelerating the improvement of diagnostic algorithms and testing to facilitate, to take full advantage of new entries, new technologies available that all point almost inevitably to decentralization and reducing the dependence from central laboratories and the length of time that comes along with those setups. And final consideration, Patty, over the last few months, we have seen huge investments going into laboratories for COVID. And one of the machines that have been very heavily purchased and distributed for its versatility, flexibility, agility in delivering results is the Gene Expert machine. probably the best example of a multiplex platforms that have the potential to profoundly reshape the functions and the layout of public health laboratories, serving not only COVID-19 diagnosis, but fortunately a wide range of diseases for which cartridges exist. So the political will and the policy change will have to take note of this. And I do really hope that research can help generate that level of evidence and data that can really inform all those policy changes that could contribute to the eventually reshape of a post-COVID health system environment. Thank you.
Thank you. Thank you so much, Massimo, for those particular thoughts. And we do hope that the current investments that are being put for the COVID-19 pandemic could also eventually translate into better health indicators within our communities. And talking about investment, I'd just like to bring in Quinn and then Yap a little bit later. So the question for you, Quinn, is about our investments in healthcare workers, our investments in community healthcare workers, and also, other tiers of healthcare workers, whether it's medical assistants or clinical officers. And you did connect this to operational research. But do you see as if there's been any diversion of their work during COVID-19? Or has the intervention remained sort of like a specialist affair so far? And then for Yap, I'd like to ask if the research papers on the impact of COVID-19 on the provision of essential health services, especially in low and middle income countries, are they affected by humanitarian crisis? You did mention that we needed a diversity of approaches, where if we need to all be safe instead of just some groups being safe. What's the opportunity or disadvantages of neglecting areas with humanitarian crisis? So over to you both.
Thank you, Moses. Yeah, thank you. So the issue around investments to do with health workers, as I said, we took advantage of the COVID pandemic. This is one disease that has shaken the politician. They've shaken the villager out there. It's shaken our ministers, even the Minister of Finance, shaken even the president. I don't ever remember a disease in Africa, maybe apart from HIV in those early years, that shook our governments the way COVID has, that brought everybody on one table, regardless of what agenda you are pushing. So when we were pushed to start to open more centers, the field hospitals, we had to negotiate for a lot more staff. We knew we were going to use the field hospitals maybe for 2-3 weeks. So the staff that was actually added wasn't just for the field hospitals. We even added staff for the rest of the health system, starting with the health center right to our tertiary institutions and all cadres, as I said, not just clinicians, nurses, and community health workers, but the lab people, biomedical technicians, engineers, pharmacists, all cadres within the health system. So we took it as an advantage to get vacancies filled that we have failed to do for the past decade, but using the COVID-19 pandemic as a bargaining tool. So that's what we've done. So they're not specifically for COVID. These are people that are working in the health system. We've closed all the field hospitals. So even the staff that we had allocated to the field hospitals, they are back in the health system. So it was a very powerful negotiating tool, even with the Minister of Finance, that they had to tweak the budget to allow us to hire not 100 people. We've hired thousands of people. I don't have the figures at the top of my head, but at least 4,000 nurses have been added, and clinical officers and doctors and the other cadres, something that we've never had previously. So we look forward that we continue to negotiate. But one of the things that I think even the research community out there should start to think about is how in an African setting we bring in integration. So traditionally TB is a vertical program, HIV is a vertical program, malaria is a vertical program, maternal newborn health is a vertical program. We've learned with COVID, when you have a pregnant woman, HIV positive with COVID, they are nursed by one team. In terms of your reporting, you need to figure out, otherwise you'll end up filling 20 registers. So we need to find a way of bringing everybody together where there's a balance between the vertical and the horizontal approaches. I think we can achieve more with a few resources that we have if we only learned the art of integration. And it's easier said than done. I moved away from the tertiary institution. I sit in the ministry now. And when you're outside the ministry, you think, oh, it's just A, B, C, D. But no. Sometimes it's actually driven by funding agencies. It's driven sometimes by researchers that are just focused on one particular area and they want to push the agenda in that particular area. So I think this is one side of things that we need to learn from COVID integration, but also how you can bargain. Don't just look at the negative side of things. Take some 2 minutes and ask yourself a deep question. What can we gain out of this that we failed to do for the past decade? Thank you.
So there are so many questions now in the Q&A, and I would like to ask each of the panelists to try to concise their answers, but also start thinking, because as we did in the previous session, at the end, I'm going to give you kind of like 1 minute to give us a summary of what you think are the urgent research priorities, okay, in this area of health systems that will help us to have more resilient systems for future pandemics, okay? That's for you to start thinking. But let me start with a question right now for Professor Boom. And the question says, Professor Boom, I'm really interested in your point about the research needed in terms of traditional medicine in your region. How much evidence is available already, and how much is the scientific take on traditional treatments accepted in the community? How could that be integrated, formally integrated in the health systems? I mean, and probably you can mention, I mean, has that been also used within the pandemic? Have we learned anything, or what are the kind of things that will be needed in terms of research? You are in mute, Professor.
C'est une très bonne question. Déjà, quand on regarde l'itinéraire des patients Covid positifs, entre le moment où ils sont positifs et le moment où ils arrivent à l'hôpital, près de 80%, dans beaucoup de pays africains, dont le Cameroun, ont utilisé une décoction, une potion ou un traitement traditionnel. Malheureusement, nous n'avons pas su saisir l'opportunité de pouvoir véritablement les évaluer. Donc, est-ce qu'elles sont intégrées dans le système de santé? Oui, parce que les populations vont les chercher, que ce soit pour la COVID ou même pour d'autres maladies. Maintenant, le rôle du chercheur et du politique, je pense, c'est de pouvoir les intégrer dans le cadre méthodologique de la recherche. Et on sait comment faire. Donc, on sait comment faire un essai clinique randomisé. Donc, on sait faire. Donc, il y a besoin d'une volonté politique pour intégrer ces praticiens, ces possibles évidences, et les tester comme on testerait d'autres médicaments. Ça nous donnerait beaucoup plus de pouvoir pour pouvoir convaincre. On a vu à Madagascar, avec la COVID-19 organique, par exemple, finalement, on n'a pas eu suffisamment d'évidence, mais il y a beaucoup qui gagneraient à être testés, évalués selon les standards et donc améliorés. Donc, je pense que c'est une bonne opportunité.
Thank you so much. So we have a question here for Professor Dub. What are the greatest gaps in implementation, and what, in your opinion, should research be targeting to improve the effectiveness on the delivery of public health services? So we're starting to enter on, I mean, what are the greatest gaps in implementation? And and the next question for Dr. Sabina Rashid, kind of goes into the same area. I mean, what do we need to learn, or what is the type of research that we need to work on regarding community engagement, community empowerment, or community-centered interventions?
Thank you. It's a $1 million question with no simple answer. But one of the things that we need to address is the approach towards implementation research. Top-bottom versus bottom-up approach. And from our experience, what really works very well is something that meets you in the middle. So bottom-up and a little bit of top-bottom. I will speak particularly for Africa that has beautiful policies, beautiful guidelines. We have no shortage of strategy documents. Our challenge is implementation. And many, many times, because it's a heavy top-bottom, we don't actually achieve what we had set out to achieve. So I think we really need to start to look at bottom-up, where things are really generated from the ground. The ground is empowered and has actually takes the people at the top into account. Thank you.
Professor Sabina?
Hi, I was going to say call me Sabina, but hey, I've been working in public health for a long time. Like in Bangladesh, I came here in '93, it's 2021. And I find being a medical anthropologist, somehow when you look at pandemics and infectious diseases and a lot of these issues, it's a very much the domain of epidemiologists, which is good. I'm not blaming epidemiologists, but I think social sciences becomes the periphery. And I think social sciences needs to play a more critical role with other disciplines, because you have a hierarchy of knowledge. And who are the knowledge bearers, and what data and what kind of data are valued is going to be a problem as we move forward. Because I think if you look at my presentation, when we were talking about community engagement and vulnerability assessments, it is at the heart of trying to understand responsiveness, preparedness. If you look at what happened with Ebola, some of the issues were around burials. In Bangladesh, the stigmas around burials and uptake of services and worrying about quarantine and isolation. It's about telling people to wear masks and wash their hands where you're living in crowded, congested conditions. So when we talk about communities, we have to remember public health cannot be a one-size-fits-all. We cannot just have a primarily clinician task force approach. We really need to reach out across disciplines, across actors, be it multi-sectoral, but even research and qualitative longitudinal ethnographies, you may call it, vulnerability assessments are critical to understanding some of the nuanced complexities of people's lives, their needs, their decisions. I want to emphasize, because I live and work in Bangladesh and I work in many slums and villages, communities, they're diverse, they're extremely pragmatic. They're very resilient, and they often have very good local solutions. In the slums I worked in, they came up with their own form of rotations to avoid and manage distancing. So I think we really need to unpack our ideas of what we mean by communities, allow for these longitudinal vulnerability assessments. We really need to expand the notion of risk beyond biomedical. I'm sorry, I'm being a bit dramatic. Otherwise, there's a train wreck that's going to happen if we keep going along the paradigms that we keep working on. Finally, I do think we need to empower communities by recognizing they are stakeholders. They're not someone we extract data from to just get information from, and then we make decisions top down. And I think that's what's really exciting about Sonar Global, but a lot of the work I'm involved in as an anthropologist, because it's really shifting the way you understand and work with communities, with them in research design, and then think through, what do we mean by responsiveness and preparedness? Thank you very much.
Thank you, Sabina. So Massimo, over to you. There was a piece of data that I think you shared with us. Losing even up to 10 years, a whole decade of gains that we would have made in TB. So the question to you really, if you would address, supranational organizations, people seated in those, funders, people interested in regional research, and even the researchers themselves. What are some of those things that we really need to focus on if we are to keep on top of these issues that you mentioned?
Thanks, Moses. These are obviously challenging questions, but I think we are not naive and we are not lacking good equipment to respond to these challenges. If I may take the example of TB as a paradigm for many other communicable diseases that are epidemic prone and the responses to those, I think we need to move ahead quickly with, on one hand, the tools that have become increasingly available. We still see a huge delay and a very slow pace of technology transition. For example, we all know how many gene expert machines have been purchased by the national programs, through the Global Fund, through donor agencies, and located into TB laboratories and locked into those TB laboratories, with the result of having a relatively low efficiency and very low usage. Now, the COVID-19 has shaken up all this environment because the demand has been urged to have immediate laboratory answers. We all want to have COVID-19 results for a molecular testing. The molecular diagnosis is a highly promising area of development that is not yet fully implemented, and the potential is huge, pointing to the second element of transition, technological transition, towards better integration. Integration doesn't happen in isolation. It's the result of political investment. Make sure that at the Ministry of Health, Queen and Sabina, colleagues who are operating in the interface with public health systems, make sure that integration happens by merging, to the extent possible, vertical programs from the top level all the way down to the service delivery point. Reposition the patient at the very center of our planning. Consider technology and strategies and experiences as tools, not as instruments of verticality for the sake of themselves. And engage communities. As I mentioned, really, we also need to broaden the scope and the agenda of civil society organizations, not to be limited to a single disease perspective that, of course, embraces any life cycle steps, etc., but at the end of the game remains limited to a single disease. We need to broaden the scope and the perception that access to health, universal health, is in the best interest of civil society organization, and we have to keep investing on them so that activism can be put at a broader service for a larger variety of topics, and then make public health really become the connecting line against all these verticalities. And allow me a final reflection on the fragility of procurement and supply management, the logistics that are behind. If we want to fit all these systems, we have to ensure appropriate logistics exist, and we have to unmask profound vulnerability also to preserve the ecology and the sustainability of those systems. The continent of the Americas was in shock to be confronted all of a sudden with a halt in global transportation, air travel, maritime transportation, and shipment of commodities. And we suddenly realized the huge degree of dependence on the global pharmacies. Most of the medicines being used in the continent are actually coming from elsewhere. And this is not a sustainable, balanced way to provide and to continue supply the needs of all these public health efforts. So I think if we move forward, and I would like to echo some of my colleagues in the panel comments when they said let's look at the COVID-19 as a huge, tremendous opportunity. There's an increase in the epidemiology understanding. A lot of words that had usually and typically were confined to the super specialist environment have become more and more of common understanding and common knowledge, with the daily bombardment of data, concepts, jargon, terminology that the COVID bulletins have brought on daily basis to all of us. We need to take advantage of all these opportunities. And as I said, I would encourage really the research community to pick up some of the priority topics and invest heavily on those to generate the evidence and the data that are badly needed.
Thank you so much, Massimo. And you were talking at the beginning about, for example, the opportunity of using GeneXpert. But I want to bring the point that although, for example, in countries like Peru, we had the machines, there was no option of buying the supplies. So, and that goes into your last point, the dependence of commodities. So there have been, I mean, as a region, we have seen the problem of the dependence of commodities in supplies, but also in pharmaceuticals for several of the programs that we have. So that's another issue that needs to be discussed and that usually is not very well, I mean, at least for the Latin American region, you know that because we have been discussing that it has been a big issue. So how to be independent, how to be able to manage well those kind of situations. So far, this discussion has been really, really important. I think we have seen two axes, okay? One axis that has to do with the type of research that we will need in order to try to fill the gaps that we have in these issues of health services and how to have more resilient services for future pandemics, right? And in that, I have heard that we need more operations research, we need to use implementation science, but we have heard also that we need to change paradigms. And in these changing paradigms, it doesn't need to be just biomedical. We need to do more social science. We need to work more in a multidisciplinary way. We need to see the communities not as the targets, but also as the participants, because they can bring also the innovations. And we have heard that innovations can be technology, definitely, digital technology, telemedicine, etc. But the innovations could be also how do we work together with the communities and how do we integrate health services and how do we have a more participatory work. But what I have heard also is that there are some examples, but examples are not enough. Probably we need more systematic ways to study that. So that's one axis, the types of research. But the other axis are the areas, because we still have areas. We have talked about how do we identify and reach and work better with vulnerable populations. And it's not one, it's like there are so many types of characterize these vulnerabilities. We have talked about maternal and child health. We have talked about the gaps in immunization programs. We have talked about traditional medicine and how that could be helpful or may not, and sometimes maybe mixed with fake medicines and fake information. But we have heard also that involving non-traditional or non-formal workers in health, let's call it traditional healers or pharmacy workers, that could be also a great opportunity. But I would like to bring one topic that we have not discussed, okay, because we have been talking about infectious diseases. So do we have any experiences, or what do you think we should be doing? I mean, what has happened with people with non-infectious diseases, with chronic diseases during COVID? I mean, what are the gaps? What is happening in our countries? What has been done? What is happening with cancer? I mean, here in Peru, I heard some experiences trying to reach people with palliative care through local municipalities, okay? But in a non-systematic way, what is happening? Do you have any experiences? I would like to give a few minutes to each of you to see if you have any experience of, or if you think, I mean, what are the gaps that we have in that area? Let me start with Dr. Diop, then Sabina, then Massimo, and Dr. Boom. Just briefly, do we have something? Is there something that we need to do? What is happening with chronic diseases and cancer during this COVID area? Dr. Diop.
Thank you. For cancer in our setting, there were no major changes. For non-communicable diseases, TB, not TB, hypertension, heart diseases, and other non-communicable diseases, we had to make changes in the number of clinic attendances. So we'd issue out drugs for a bit of a longer period of time. We had to capacity build, particularly for the urban settings, peripheral health centers that normally would not be looking after these NCDs. So we had to capacity build them and build in a mentorship and supportive supervision system. So people are seen closer to their homes than all the time coming to a bigger tertiary facility. Thank you.
I'm going to keep it brief. We don't have the greatest care for cancer anyways. Our health systems is quite weak. It's not that strong. Something like COVID made it even worse. Patients were turned away. ICUs were overflowing. Doctors were stigmatized. Doctors were turning patients away. PPE was of poor quality. I mean, there was a huge challenge. And we're anticipating now, again, ICU beds are filled up. So in general, health services kind of, people didn't know what to do, where to go, mass confusion in the middle of a lockdown. If that answers. Thank you.
Massimo.
Patty, I'm very glad that you raised the issue, because maybe excessive focus on communicable diseases may have generated the impression that most of the impact of COVID is on that area, which is not true, of course. This is a very transversal impact that affects the whole of the capacity of maintaining essential health services. And certainly NCDs are no exception to that. There's probably some data available, as much as all individual programs have been struggling to collect, to document, to measure, to project, to estimate. From our perspective, being particularly HIV bordering or overlapping, better said, into provision of chronic care, there are certainly signs of worries in terms of worsening indicators across the board. And I think the same reflections that we have for the time being limited to communicable disease are heavily, if not entirely, applicable to the whole spectrum of NCDs. With probably the disadvantage when compared to areas like HIV of not relying on equally active and vocal communities and civil society organizations. Thus, my call to really push for expanding the agenda of civil society organizations, not to be locked into the vertical exclusive approach, but rather to develop, and quickly, a culture of transversal, horizontal, and more integrated approaches, because activism is likely to be one of the key answers to keep the focus on these challenges and issues vis-a-vis the post-COVID phase and hopefully the reshaping, reconstruction. And I'm using these words because Latin America, and in particular, has been really very heavily affected and continues to be very heavily affected by the pandemic. And so nobody really knows what would be the final toll on health systems after 1, 2, or God knows how many years into this nightmare.
So thank you so much, Massimo. We've just about run out of time there. But maybe if I was just to find out from each of our panelists, if you were to make an investment in health systems during this particular period, what will that area be quickly, if that's possible? And then we cross. Yep. if you're to make an investment in health systems at the moment, what is that area?
It will be on diagnostic, definitely, because the earlier we can find a disease, the better we can take care of our community.
Okay, thank you so much. Sabina, any thoughts?
I would phrase it like investment in longitudinal social science research with communities and looking at health systems more closely to understand some of the key issues that have actually been barriers to care and how to improve that. So you have communities involved and engaged when you look at it through a social science qualitative perspective. That's what I would put my investments. We want change.
And Quinn, any thoughts?
I would like to invest in primary health care. You know, one of the things that we've learned with COVID is prevention is better than cure. And when you talk about prevention, you're really talking about primary health care, but also not neglecting the secondary and the tertiary, but really work at that primary health care level. We lost a lot of people just because of late presentation. And where does that happen? Primary health care level. So I would like us to look at that and see how best we can strengthen even the referral pathways. Thank you.
Thank you. And finally, Massimo.
Thanks. I would certainly recommend to invest on drivers of integration and focus on health systems. There's a galaxy of health systems out there, multi-dimensional, all of them with its own driver: laboratory, health information systems, community participation and involvement as an extension of formal health systems, investing on health workforce, on policies. I mean, there's a broad spectrum of potential interventions, but the key word is really drivers of integration.
Thank you. Thank you so much. I'd like to just take the opportunity to thank, first of all, my co-chair, Dr. Patty Garcia. Thank you so much for doing such a wonderful job for this particular session. And then, of course, all our panelists for today, and also everyone else who listened and engaged and asked the questions and also wrote within the chats. We absolutely enjoyed this session, but more importantly, we did gain quite some information from the various different regions of the world and also the various different organizations. There's definitely a sense of urgency for the now, but it's also come out very clearly from the panelists that even as we take care of the now, the COVID-19 pandemic, we also have to maintain an eye for the future in terms of strengthening other areas of health research. So thank you so much for listening to us. We are just a bit over time, and I'd like to hand you over to Cesar Atua. Thank you so much.
Hello and good afternoon, everybody. Thanks to the organizers for actually inviting me to wrap up today's reflections. The day has been extremely rich, and I just want to share with you some reflections on what we've been hearing, and also comment on perhaps new pathways or possible pathways to enhance on the good that has already been done. So let's move to the next slide. The first thing, I'd like to start with an Igbo proverb from Chinua Achebe's Things Fall Apart. He says, at one point, a naked bird says that since humans have learned to shoot without missing, he has learned to fly without perching. Here, this proverb is trying to say that when things change, we need to change strategy. And I think one of the greatest lessons that we're learning from this pandemic is that some of the things that we've been doing require some amount of change if we're to be able to adapt and face the new circumstances that have arisen as a result of the COVID-19 pandemic. So I just want us to take a look at some of these and then share some reflections. Let's move on to the next slide. Of what we've been hearing today, really some great and remarkable achievements have been made because of scientific discovery, international and interdisciplinary collaborations. Even this meeting, which we are holding today, organized by in international collaborations, and even the occasion for funders and researchers to meet. All this has been occasioned by COVID, and I think there is a good deal of positive energy and positive resources here. Even the discovery of vaccines that are being rolled out now is also a result of a great deal of scientific collaboration. And I think these are things that we need to capitalize on as we're going forward. At the same time, the pandemic has also revealed what we call a shared vulnerability in terms of the fact that this virus, which is attacking everybody across the world, shows that we are all together playing as a team. And in this game, as a team game, if we may use this image, it doesn't matter even if you are the highest scorer. If your whole team doesn't win, no, you will not win. So let's say the world in its interconnectedness is standing together as a vulnerable entity in the face of the threat of the COVID-19 pandemic. However, we've started using this term interconnected a great deal. And what has been revealed today is that even though we are interconnected in a way that is unequal. And therefore, the vulnerabilities or even the opportunities that exist are not the same across board. And this is something we need to take into consideration, especially when we're talking about research funding. Solidarity, which is often confused with interconnectedness, is that normative dimension that asks for some degree of fairness or equity within the interconnected relationships. A great deal of interconnectedness that one can think of if you think of the African savanna or the African, the African savanna. You do have animals that feed on others. I mean, lions may feed on zebras. They are interconnected, but at the same time, one cannot talk about solidarity. So interconnected is not necessarily a guarantee that there will be solidarity. And what we now, this also that is that there are great opportunities that are coming up really for a good deal of results. What we've seen being done in Latin America, what we've seen being achieved as well through the Africa CDC, and all the other research that is being carried out through international collaboration shows that, yes, we have an opportunity to include more people, and we will actually gain more through greater inclusion. However, there is within this form of inclusion and this greater form of collaboration, a problem of hegemony, whereby, yes, people are included, but not included in the same way. So there is no equity in the sharing. And this we see in research in terms of access to resources, access to funding, access to publications, and even the sharing of benefits of research. Let's move on to the next slide. Okay, so if we think of the research world as a microcosmos, I think I have just about 5 minutes. So the research world as a microcosmos. What has also emerged is that in this world of research, we work within a context, and this context includes politics, it includes law, it includes structural inequalities. And therefore, as funding is being directed to research, we need to keep in mind that this research occurs within an environment. And this environment can actually place structural limitations to what researchers can do. And therefore, one of the areas which we need to work on as we move along, and even funders and governments need to actually help us move ahead in this, is to create favorable conditions for researchers to be able to work. Therefore, to pay attention to the other elements that surround research. And also, this will influence the uptake of research. And in one of the earlier presentations, it was mentioned how governments and policymakers sometimes do not dialogue with researchers. These are things that we need to improve upon as we're going on. And then there is also the fact that, yes, while we're talking about inequality, one of the reasons why sometimes, for example, in data collection and secondary data analysis, we talk about people in LMICs just being reduced to being data collectors, whereas the research and the publications are done outside in high-income countries. And one of the responses to this is to increase capacity enhancement. But yes, capacity enhancement is important. And at the same time, this capacity enhancement should not also be a form of epistemicide, so that we can simply just copy what is happening in HICs and transfer it directly to low-income countries without taking into consideration the contextual differences. The question of procedural harmonization, yeah, this has also been mentioned. We can talk. That is something that we need to look at. But the key thing about funding is that I think there is a need for subsidiarity when we talk about funding. We notice that priorities change. There are gaps in knowledge, and these gaps are different according to geographical regions and even within countries according to social context. The important thing is to ensure that the intermediate structures, researchers who are closer to the ground, are empowered to be able to decide on the priorities that actually affect their context. That way, they will be carrying out research that is useful to the context in which they are, and for that matter, they will also feel to some extent accountable towards the people they are supposed to be serving. Now, the other area that is important in terms of research collaborations, apart from the need for greater equity, which is important, is the need to build trust. Now, building trust requires three conditions. One is that, people can be trusted if they are competent, they are reliable, and they are open to be accountable. Now, for the moment, most of the time, researchers practice this form of accountability and reliability and competence in relation to the funders. So they try to appear competent, reliable, and accountable to funders. But this is not the only type of trust that is needed. There is also trust that is needed with regard to the communities, with regard to the people who are the ultimate recipients of this service. And we will need to devise systems whereby we can actually make ourselves accountable to the people and the communities that our research is supposed to be serving. Let's move on to the next slide. And this will be the last one. Now, since we're meeting funders, from the things that have been said today, some of the ideas that I would just like to underline before we close are the following. Funders need to start looking at structural initiatives to build robust local research environments. If we think of the fact that scientists carrying out research have been able to come out with a vaccine in such a short period of time, we were able to come up with diagnostics in a short period of time, is because these environments were robust. These environments were well funded and well organized. Now, if we want data to be able to carry out other forms of research linked to the pandemic, we need to make sure that while we are, that the environments are sufficiently robust, which is empowering people, training people, and making sure that when we need data or when we need to carry out certain research, we should be able to do so. This morning, people mentioned the fact that, for example, more than a year after the outbreak of the pandemic, we really do not have enough data about what is going on in Africa, for example. Local researchers, as I said before, should be involved in setting the priorities because we keep talking about gaps. But these gaps, which gaps and whose gaps are we talking about? And I think the local researchers are the ones who can actually identify the gaps in the areas in which they work. Now, capacity enhancement is also another important point which people keep talking about, but let us remember that capacity enhancement is not a form of epistemicide. Capacity enhancement means also accepting that there are other forms of knowledge and people can hold knowledge that may be different to the knowledge that perhaps our colleagues in higher income countries are used to. So, capacity enhancement means actually broadening the base of capacity and sharing capacities. And then for funders, the most important thing is that funding is a service to research and to health. It is not power. And if it is a service, then that service should actually be behind and asking what can we do to make sure that the money we are spending produces the greatest impact in terms of health outcomes for the people we are serving. It is not for the funders really to dictate what research ought to be about. And the same thing applies to researchers. We should not be doing research by following what calls are available and what funding is available, but we should be in a position to be able to ask what are the priorities at the moment and what is needed and what are the knowledge gaps that we have to fill with our research. Some concrete measures for future pandemics, data sharing, for example, has been mentioned, and equitable platforms need to be created for biobanking so that we'll be able to share data in a harmonized way and in a way that this data can be made available, especially in the cases of pandemics, which do not know barriers. Procedural harmonization, I've already mentioned that. Also with regard to ethical reviews, because sometimes ethical reviews can delay and can be repetitive, but there we need to distinguish between what is the science and what is the context in order to do a harmonization of ethical reviews and the stronger collaborations. But finally, as we keep talking within the science community, let us also keep in mind that there is knowledge that we are unaware of. As I think of the African context, I think of our people who for centuries have had forms of healthcare, traditional forms of healthcare, and they are healthy. And some of them are actually performing better with regard to COVID than we imagined. We do not know. And let us not disregard actually going in with a humbler attitude to study what knowledge they have. And let us not think of that knowledge in terms of genetic fallacies as an inferior form of knowledge. And with this, I end. Thank you.
Thank you very much, Cesar. We will look forward to seeing those of you who can join us at the meeting tomorrow at the same time. And please see the details on the websites. Thank you everyone for joining today. It's been a really useful discussion.